protease, matrix protease, eosinophilic cationic protein from eosinophils. The newly synthesized cytokines, which are released from the mast cells, are interleukin 4, 3, 5, interleukin 13, tumor necrosis factor alpha, platelet activating factor, prostaglandin D2, and leukotriene C4. So here Th2 cytokines are involved in the activation of eosinophils and other leukocytes. And chronic allergic inflammation is a type 4 hypersensitivity reaction. So how allergy develops? Whenever a person gets exposed to allergen is usually taken up by dendrites. Dendrites are also called as antigen presenting cells because they present to T cells. So they present to naive T cells which get transformed to Th2 cell. Simultaneously, the B cells get transformed to the plasma cells which produce IgE. This IgE binds to the mast cell which has a receptor FCERI. So whenever a person gets re-exposed to an allergen, the allergen binds to the IgE which is already bound to the mast cell. So this is called as switching. Whenever there is a switching occurs, mast cell degranulates, means it releases granules. So the granules are vasoactive amines and the cytokines. These vasoactive amines and the lipid mediators are responsible for the early phase. So, and it lasts for the minutes after the exposure of the allergen. Whereas cytokines are responsible for the late phase, which lasts for 2 to 24 hours after the exposure of allergen. So, what are the actions of these mediators? The cytokines like interleukin 4, 13, 3, 5, tumor necrosis factor alpha, transforming growth factor alpha, and transforming growth factor beta, these promote inflammation, they amplify Th2 response, they activate eosinophils, and they causes epithelial proliferation. Whereas enzymes like tryptase, chymase, carboxypeptidase A, eosinophil peroxidase, eosinophil collagenase, matrix proteinase, these all causes tissue destruction, connective tissue remodeling, and matrix protein degradation. And like arachidonic acid metabolites like prostaglandin D2, leukotriene C4 causes smooth muscle contraction and increased vascular permeability. Because of the smooth muscle contraction, in case of bronchial asthma, it causes bronchoconstriction. And because of increased vascularity, it causes edema. Because of the histamine release, it causes redness at the local site. So, what are the disorders caused by allergy? These can be anaphylaxis, which can be caused by drugs, bee sting, and the food, bronchial asthma, allergic rhinitis, sinusitis, food allergies. Food allergies are usually caused by wheat, egg protein, and brinjal. So, these what are the types of allergies? These are allergic rhinitis, skin allergies, food allergies, drug allergies, latex allergies, and anaphylaxis. So, what are the clinical features? So, the clinical features can be prodromal symptoms, means patient feels anxiety, parastatic rich sensation of the palms and the soles, cutaneous manifestations like pruritus, flus, urticaria, respiratory manifestations like sneezing, rhinorrhea, dyspnea due to laryngeal obstruction, tightness in the throat, cough, wheezing, cyanosis, and lastly, respiratory arrest. And cardiac manifestations like early tachycardia, changes in the blood pressure, arrhythmia, shock, and cardiac arrest. Gastrointestinal symptoms like nausea, cramping, vomiting, diarrhea, and urination. Non-specific symptoms like sweating, headache, and disorientation. Based on the severity of these clinical features, we have 4 grades. The grade 1, where we see cutaneous manifestations like urticaria, flushing, and angioedema. In grade 2, along with the cutaneous symptoms, we have cardiac symptoms, tachycardia, so hypotension, rhinorrhea, hoarseness, breathlessness, and nausea. In grade 3, along with the cutaneous symptoms, we have shock, laryngeal edema, wheezing, cyanosis, nausea, vomiting, diarrhea. In grade 4, along with the cutaneous symptoms, we have cardiac and respiratory arrest, nausea, vomiting, diarrhea. So, as I told you, the clinical features are difficulty breathing, wheezing, coughing, hives and the rash or the itching, sneezing, running nose, red or the watery eyes in case of allergic rhinitis, nausea, vomiting, diarrhea in case of food allergy, swelling of the face, mouth, tongue, and the throat in case of anaphylaxis. So there is a link between rhinitis and the asthma link. According to World Health Organization report, allergic rhinitis and its impact on asthma. It states that 30% of the patients with rhinitis develop asthma and 80% of the patients with asthma have a rhinitis. So there are few similarities between asthma and the rhinitis and the few differences. What are the similarities? Similarities are the lining epithelium is same, that is pseudostratified epithelium. Pathogenesis is usually driven by Th2, and treatment response is usually by the corticosteroids, anti-leucines, and anticholinergic agents. What are the differences? Differences are the erectile venous sinusites are present in the nose, and disruption of the epithelium with thickening of the subbasement membrane zone in the asthma, whereas the epithelium is intact in rhinitis. And there occurs air modeling in asthma, and antihistamines are effective in allergy, whereas beta agonists are effective in asthma. How do we diagnose a patient with allergy? By these diagnostic tests like skin prick test, intradermal test, serum Ig, basophil activation test. About this, our speakers will be telling in detail in further sessions. And about the treatment, the first treatment is always prevention. So we ask the patient to avoid allergen, and pharmacotherapy like antihistamines like cetirizine, fexofenadine, pheneramine, mast cell stabilizer like sodium chromoglycate, leukotriene receptor antagonists like montelukast, corticosteroids like hydrocortisone, fluticasone, and mometasone. Immunotherapy is the only proven curative approach. About this, our speaker will be speaking in detail in further sessions. Thank you.
Thank you, Dr. Savita, for making the basics simple and easy to understand. I now invite Dr. Ashwini S. Dodmani, ma'am, Associate Professor, Department of ENT. Ma'am has been a constant source of guidance and cheer. Ma'am, please come forward and introduce to us all our first speaker for the day.
Good morning, everyone. It's my privilege to introduce our speaker for the day, Dr. Soumya MS. Madam is working as right now as a senior consultant at Narayana Health, Bangalore. She was an ex-professor in Department of ENT in St. John's Medical College, Bangalore. She completed her MBBS from the MS Ramaya Medical College, MS ENT from Bangalore Medical College, and she was awarded a fellowship in allergy and rhinology from University of Leuven, Belgium. Madam has more than 15 years of teaching experience. She worked as a tutor in BMC, assistant professor in Rajeshwari Medical College, and she worked as assistant professor, associate professor, and professor in St. John's Medical College. So, Madam is awarded as Leading ENT in Healthcare Innovation Awards 2024, and she scored highest marks in MS ENT exams in the year 2008. And Madam was awarded with Dr. Brinda Memorial Award for securing highest marks in OBG. She was a medalist for university in the following subjects: microbiology, pathology, pharmacology, forensic medicine. She was awarded as the best outgoing student for MS Ramaya Medical College for the batch of 1996 to 2002. And she secured 19th rank for Karnataka State in SSLC. Madam has secured various prizes in PG quiz competitions. She was the first Indian doctor to be awarded a clinical fellowship by European Academy of Allergy and Clinical Immunology. Madam has various additional courses like basic course in biostatistics, advanced course in biostatistics, allergic rhinitis and sinusitis workshop, qualitative research and methodology, and fellowship in allergy and rhinology. Madam has more than 15 to 20 publications and research projects which has been completed and which is ongoing. In that, 5 were funded by the ICMR, which like pollen calendar, rural versus urban, correlation between airborne pollen incidence, skin prick test, and serum IgE in patients with allergic rhinitis in urban versus rural settings, pediatric obstructive sleep apnea, assessment of predictors, benefits of surgery in mild OSA. So these are the various research projects which was funded. Madam was invited for the various talks as a guest lecture. She was invited as an audit of in talk for audit of allergic clinic in St. John's Medical College. She was invited as faculty at Milan to give a talk on olfaction at the Conference of Allergy and Asthma. She's given talks on various topics like allergic rhinitis, vertigo, its management, coagulation assisted surgeries, and other topics. So I don't want to take much of the time. So I'll not be reading it in detail, just a few points. So there are a lot of, so many guest lectures ma'am has given and various video presentation. And ma'am has organized various conferences. Internationally, she was invited as a guest speaker in Milan, Italy to talk on olfaction. And she was invited as a faculty to talk on diagnosis of rhinitis in Abu Dhabi, and she attended a World Allergy Congress, Seoul in 2015. And she gave a talk on pediatric obstructive sleep apnea in Congress at Sweden. And also, she gave a talk on pediatric OSA and allergic rhinitis in a conference organized in Bangkok in 2018. So, ma'am is she has completed a fellowship in allergy and rhinology awarded by the University of Leuven, Belgium. So ma'am has a membership in Secretary, Indian Academy of Allergy, India, AOI Karnataka chapter, and Association of Otolaryngologists. The area of interested, ma'am is interested in pediatric otolaryngology, allergic rhinitis, asthma, FES, pediatric sleep disorders. So thank you, ma'am, for making time in your busy schedule and accepting our request to attend the CME and deliver the guest lecture. So I now request our speaker to enlighten us more about aeroallergens and prevention of allergy.
That was an elaborate discussion, introduction to our guest speaker, Dr. Soumya ma'am. Ma'am, a very inspiring career graph. Now moving forward, we'll understand more about the invisible triggers in the air, aeroallergens. Our speaker for the day, Dr. Soumya ma'am, will take over. Session will be chaired by Dr. Shivkumar sir, Professor and HOD, Department of ENT, and Dr. Narayan Swami sir, Senior Consultant ENT Surgeon at Kavita ENT Clinic, Tumakuru.
Very good morning to all of you. I'm very happy to be here. This is my second time coming to Sridevi Medical College, and earlier I had delivered a talk on OSA. What makes me happy is the fact that the ENT department is very active, very nice, and more than that, my teacher, Dr. Shivkumar, he was there as my teacher when I was in BMC in Bowring, in my postings in Bowring Hospital, and a very nice person, very nice teacher, gave us a lot of cutting chances, and we all have great respect for him. So I'm very grateful to you, sir. Thank you so much. And it's my honor to be talking in front of you, sir. Thank you, sir. And also, Dr. Narayan Swami is from the same college that I graduated my MBBS from MS Ramaya Medical College. So nice to know two people here. And the Department of ENT, Dr. Ashwini has been taking a lot of interest in trying to promote it in many ways. So she's doing fantastic work and she has an excellent team. Thank you so much for calling me and also for the elaborate introduction that you gave. Thank you. So now today I'll be speaking about allergic rhinitis, and Dr. Puneet will be talking about asthma. So, these are two very, very important things in practice. Now, after you attend to any talk or you're attending a conference, there should be something for you to take home. Okay, something that you can apply in your practice, and it should be meaningful. It should not be like an hour wasted. So, I will tell you first of all why allergic rhinitis is so important and why this CME today is so important. So, if you like search PubMed and put the search word allergic rhinitis, between 1945 to around 1975, you will have around 4,000 papers. PubMed will show you that there are some 4,000 publications. Okay. And from 1975 to around 2005, you will see that there are double 8,000 publications. And then in the span of next 10 years, it is like around 10,000 to 12,000 publications are there in the field of allergic rhinitis. So what does it mean? One, it means that people are actively publishing. Yes. Also, it is important that for us to know that it is not only people who are publishing, it's also that this has become a disease of today, and the future generations also are going to be suffering. The burden of allergic rhinitis is very huge. It's overwhelming. It is putting a lot of strain on, it's one of the top non communicable diseases in the world today. And there's a lot of funding going on across several countries to get to the crux of allergic rhinitis. Now, why is it so important? It is important because we don't know how to cure it yet. We are just trying to grope in the dark. Whatever medications, whatever the pharma companies are coming, they're all trying to give symptomatic treatment. At best, we are able to treat sneezing, itching, only the symptoms. Okay. And at worst, the patient continues to suffer with so much of impact on his quality of life. Okay, so the patients will be depressed, they'll have suicidal tendencies, they will stop going to public gatherings and functions because they always have to carry a hanky with them. Or sometimes they even describe carrying like a towel. They're also sort of like outcast. So over my experience of more than a decade with patients with allergic rhinitis, because I've been very closely following them up and also have a big Excel chart wherein I monitor all their progress and things. I've seen like it is more like a social taboo. So they, girls also get find it difficult to get married because in the households they say, oh, this girl is always sneezing. So it has become like a social taboo. They're worried whether it will be transmitted. They're also worried if it's some virus like COVID or something. Okay. So that is one thing. Plus, also there is a lot of social isolation which happens. The cognitive impairment happens. The work quality or the work-life balance is affected. So there's a huge economic dent. Now, this is in the bigger scale, the bigger picture which you see in economic terms for policymakers, for decision makers. Okay, that is for them. What does it translate to you as individual practitioners? Okay, so few of you here are MBBS students. You will be like you'll finish your MBBS, then you'll write your NEET PG, then you might choose any specialty. Okay, whether you choose orthopedics or whether you choose gastroenterology. But there is one thing in common. You will definitely encounter patients with allergic rhinitis. Okay. In fact, pure allergic practice itself can be the bread and butter for you. Okay. It is extremely lucrative. Why? Because there are so many patients of allergic rhinitis. Second, it's difficult to treat them. So they keep on coming back to you. They're some sort of like a lifelong patients. Okay. So today we will try to understand what is the scientific way of trying to address this so that you can be a better doctor for your patient. And it is also important to know that allergic rhinitis is not, confined only to ENT or to the pulmonologist. It is the entire system. It's an allergic process. Okay, like in the previous talk, Dr. Savita had told about all the pathophysiology and the mechanisms, how it happens. So we know that there is things which is happening at the micromolecular level, which is triggering an inflammation throughout the body. So it could be allergic dermatitis, it could be food allergies, it could be atopies, it could be celiac disease, it could be gluten sensitivity. There are so many different things, and there's a lot of overlap between all of this. So at the end of this talk, what I would like all of you to take back is that there is a very scientific approach to seeing patients with allergic rhinitis, the importance of taking history for patients with allergic rhinitis, and how will you narrow down your choices to say, okay, this is what it is, so that you are able to give them specific tailor-made treatment. It is not like some blanket treatment that you're going to write a levocetirizine for anyone who comes with allergy. Okay, you will be able to apply that in practice. So 300 million people worldwide have asthma, and 50% of them live in the developing countries. And also, it is staggering to know that around 400 million people suffer from allergic rhinitis. It's interesting to also note that Bangalore itself has become the allergy capital for India. This is because there is a rapid urbanization which is happening. There's so many trees being cut, and where every day there is construction happening and something or the other. Okay, so there is a lot of environment urban conflict. So because of this, we are having lots of patients of allergic rhinitis. The other area is Delhi. All of you are like, when you think about Delhi, no, the first thing that comes to your mind is AQI, the air quality index. There is so much of smog, there is so much of dust in the air and pollution that people are suffering from asthma and allergic diseases. Earlier, it was thought that asthma and allergy are two different diseases. But you can see today that we have a pulmonologist and an ENT on the same platform, because later it was realized that it was one airway, one disease. Okay? So, asthma and rhinitis will coexist in the same patients. The pathophysiology is the same. And how much is the prevalence of asthma in patients with allergic rhinitis? It's around 30 to 40%. Adults and children with asthma will have regular hospitalizations. Okay, the physician visits will be there, higher asthma drug costs will be there. Okay, than adults with asthma alone when there is a comorbidity or they both of them are together. Now, if you go to any conference and if you see, who's the main sponsor for all the conferences, the big conferences, usually it will be lots of pharma companies putting money into allergy. Okay, you have every day you have one new antihistaminic coming. We started with chlorpheniramine maleate. Now it is like after that it was levocetirizine. Then you have fexofenadine, azilastin. Now the latest on the market is bilastin. Okay, there is continuous research in it because, like I told you, it is very lucrative for them. The same thing does not hold true with antibiotics. So that is one of the other things which is giving rise to superbugs. Okay, so there's a lot of pharma attention on allergic rhinitis. Now there are several different phenotypes. Now, what's a phenotype? A phenotype is what a person will present with on the outside. Okay, what is seen on the outside is called as a phenotype. What is inside is the genotype. So the phenotypes can be like allergic, it could be infectious, like viral infections. It could be non-allergic, non-infectious rhinitis. It could also be non-allergic rhinitis with just eosinophilia, wherein there's lots of eosinophils in the nose. Chronic rhinosinusitis without polyps can be there. Okay. Occupational allergic rhinitis, like, latex allergy when we are wearing gloves in the hospital. Okay. Garment workers will have allergic rhinitis when they go to their particular area. Byssinosis, silicosis, asbestosis, all this. Drug induced allergic rhinitis, then it could also be hormonal, like pregnancy, menstruation, honeymoon rhinitis, hormonal contraceptives, all this. Food induced rhinitis can be there, cold air induced, and atrophic rhinitis of the elderly. Why is it important for us to know all the different phenotypes? Because it is very confusing whether when the person comes to us, first of all, we need to find out if it's an allergic mechanism or there is something else on play. Okay. If it is an allergic mechanism, then we will have to treat it as allergic rhinitis. For example, it's a drug induced, and then you're trying to treat with several other things. You don't really know that the drug is the one which is causing the rhinitis. Okay. For this, the history taking is very, very important. So like it was mentioned earlier in the talk, so allergic rhinitis is a classical gel and Coombs reaction, type 1 IgE mediated. This is for all the MBBS students who are sitting here and for who is going to write the next or the NEET PG exams. Okay, it is a classical type 1 hypersensitivity reaction. The delayed hypersensitivity reaction will be a type 4 reaction. Okay, that is mediated by the T cells. So, type 1 allergies are classically mediated by IgE, which is attached to the mast cells, and the symptoms result from allergic responses when it is very severe. There is a lot of allergen reaction with interleukins, everything being released. Patient will go into anaphylaxis. Anaphylaxis can be life threatening, and it is every doctor's responsibility to know how to treat anaphylaxis. So, some examples of anaphylaxis is hay fever. It could be acute severe asthma. Eczema can be there. Bee stings, food allergies. Okay. So, all this can contribute to anaphylaxis. So, it is also important for us to know that allergic rhinitis can also be a type 4, that is a delayed type of a response. That is, for example, contact dermatitis. So, we would have seen, so some women will not be able to wear nickel or metal earrings. They have a lot of dermatitis of the pinna lobule. So, this is like a contact dermatitis. Also, parthenium grass. You're doing some weed picking in your garden. There's some grass, parthenium, everything you're trying to take out. You might develop some rashes after a few hours. So that is contact dermatitis. Food allergy. Okay, so gluten sensitivity is one thing. Usually, it is people who come from abroad who come back. They will all be fine, and then they will say suddenly that they have lactose intolerance, and then it's very surprising. You've been growing up drinking milk. What is this? Suddenly, you come from US and then you say lactose intolerance. So this is because of what is called as epigenetics. In epigenetics, when a person goes to a different place, the genes of that person are acted upon by the environmental influence. So there could be change in the diet, in the bacteria in the gut. All this can alter the epigenetics. So a person who was nicely eating paratas, a Punjabi, comes back saying, no, he's got bloating now and he can't eat paratas anymore. Similarly, the same thing with milk also. Milk, lactose intolerance, they'll say. Then they will say, I'm vegan now, I cannot tolerate anything. Okay, this is all because of the epigenetic influences. Another thing is bronchial asthma. So, bronchial asthma also, Dr. Puneet will be talking more about it. So, it could also be childhood onset or adult onset. Okay, the adult onset has got a worse prognosis. Okay, we can, and also it is important for us to note that we can be sensitized any point in time in life. Not necessary that we are like, we were fine. There are people who have been eating prawn and shellfish, and one fine day they just cannot tolerate it. Okay, so that can also happen. So, allergic rhinitis is not a disease of isolation. It is not something which is just limited to the nose and you take care of the nose and it's gone. No, not like that. There are a lot of comorbidities associated with it. So, what are the comorbidities? We can divide it into primary and secondary. The primary ones are different types of allergic reactions, like I already mentioned, that is asthma, atopic dermatitis, conjunctivitis, polyposis, sinusitis, upper respiratory tract infections, and otitis media. The secondary ones, decreased quality of life. Now, quality of life is something which is very, very important. Most of the times in the Indian context, we don't really bother about it. But every time in your clinic, whenever you see a patient, you should also have a chart asking about quality of life. Okay. So in the Western world, they give a lot of importance to quality of life, which most of the times is ignored here. So quality of life can be impacted severely. There can be sleeping disorders. Obstructive sleep apnea can happen because of adenoids, because of the congestion in the nose. There can be learning and attention, disabilities can be there because of cognitive performances which have been suppressed by the inflammatory pathways. There can be mouth breathing, dental occlusion. These are all the associated comorbidities. So when you're seeing a patient, you're supposed to ask history about all these things. So these are a few representative pictures that I will put so that, because we have a lot of young crowd here. So this is a picture of atopy. So atopy is the first sign or the hallmark saying this child in future might develop allergic rhinitis or allergic symptoms. Okay. There is something called as an atopic march. So usually it presents as a diaper rash. So babies, no, the mothers will say, okay, we put this diaper, and then they bring the baby and say it's all red here. and the child presents with a diaper rash, or some new dress is put for the child and then there's a rash on the nape of the neck. So this is a telltale sign that this baby is atopic. In future, it might develop allergic rhinitis, it might develop asthma, then it goes on to become food allergy and contact dermatitis. So this is the atopic march. Then this is a case wherein anaphylaxis, there is angioedema, severe swelling of the lips can be there. Okay, and it could be very dramatic. Patient might have a lot of difficulty breathing, and you will need to immediately resuscitate the patient with hydrocortisone, with adrenaline. Sometimes you will also need to do a tracheostomy if the breathing is compromised. This is chronic otitis media. So here you can see that this is the normal tympanic membrane, normal middle ear space, and this is fluid collected behind the middle ear. This is called as chronic otitis media, sorry, serous otitis media. In serous otitis media, there is what is called as glue ear. Thick secretions will be there behind the eardrum. Because of this thick secretions, the child's hearing will be decreased, because the eardrum is not able to, here it can move well, no? You have the malleus, incus, stapes, all of them can move. But see here, there is so much of thick fluid, mucus, which is present, as a result of which the eardrum does not move. So the child can present with decreased hearing. Okay, so the mother will bring the child to you and say that, they will not say that the child has got decreased hearing. Usually it is not even recognized or noticed by the parents. Rather, the teacher will complain that this boy is very inattentive in class. He's simply running from one place to another, never does his homework properly. All other children are listening to instructions. Only this boy is not interested. Then there's so many complaints about that small little boy that then the parent teachers meeting is called. And then the mother is forced to take it to a child psychologist. The child psychologist will say, he's got attention deficit hyperactivity disorder. And then they will start him with all sorts of, psychiatric medications and antipsychotic, and just to calm him down. But before doing all that, it is very important that you please have a look into his ear. Just see if the tympanic membrane is looking pearly white, okay, or if it is looking dull. And then you can do a simple test which is called as a tympanometry. In a tympanometry, if there is fluid like this, you will see that there is a flat curve. There is a flat curve and the tympanic membrane will not move well. So just treating this, you will improve the child's attention and everything. Okay. So this is one more comorbidity that you should keep in mind whenever you see the child is very hyperactive and the parents complain that the child does not listen to the instructions. So this is another picture of serous otitis media where you can see bubbles. See, there's a lot of bubbles, air bubbles are there and fluid is there. Okay, this is how the child might present. Chronic tonsillitis, all of us know about it. All of you as UG students also would have seen chronic tonsillitis. Okay, huge tonsils will be there. This will be because of recurrent adenoiditis, because the adenoids will get swollen up every time there is allergy, and it can lead to tonsillitis also. So there is a lymphoid hypertrophy. Sinusitis. Sinusitis is another thing that the patient might present with, because there are boggy turbinates. In allergic rhinitis, patient will have pale mucosa with boggy turbinates. This boggy inferior turbinates and all that will occlude the sinus drainage, as a result of which patient can have sinusitis. Okay, so here you can see that this is a hypertrophied turbinate. Okay, and it is blocking the osteomeatal complex. For the undergraduate students, the osteomeatal complex is the place where all the sinuses will drain. Okay, the anterior group of sinuses will drain. So if it is not draining, this secretions will collect there. These are polyps. See, this is also because of allergic rhinitis. And usually polyps are seen in above 40 years. Okay, there can be bilateral ethmoidal polyps, we say. This is because of chronic allergy. They will be exposed to allergens for a long time. They might have a cat at home. They're very attached to the cat. They don't want to let go of the cat. They're okay to suffer from the allergy, but the cat is very precious. Okay, so this is one of the things, one of the reasons for chronic allergies causing bilateral ethmoidal polyps. Okay. So on histopathology, you will see lots of goblet cells. Goblet cells are the ones which are secreting the mucin, and there is also eosinophilia. Eosinophils are the marker for allergy. So how will you diagnose allergic rhinitis? One is history taking. So patient will come to you and he will say that he's got excessive sneezing, itching of the eyes, itching of the ears, itching of the palate. So history taking, okay, these are symptoms which sort of fit into allergic rhinitis. Okay. Then you will do the clinical examination. Like I already told you, you're going to see that huge turbinates, pale mucosa. And because the child will always be, rubbing the nose like this because of the allergy, he will have what is called as an allergic salute. An allergic salute is a black mark over the dorsum of the nose. They will also have black dark circles under the eyes. Okay, so dark circles under the eyes does not mean that they've been studying too much for their exams. It could also mean it is because of allergic rhinitis. Okay, so they're called as allergic shiners. So you see this, then you do a nasal endoscopy. You take the smear from the nose, the nasal smear, and check for eosinophils and other cells in the nasal smear. And when you're doing the nasal endoscopy, it's a very simple technique. It's something that you can all learn. You can do it bedside also for the patient with minimal anesthesia given. So now you have done that. You also do some blood tests, but it is important for us to know that the absolute eosinophil count, the total IgE, both of these are non-specific. Okay. So total IgE can be raised in many conditions, even the absolute eosinophil count. Even if the child has got a parasitic infection, worm infestation, even then it can be raised. So it is just given more like, you're just like a paraphernalia of tests, but that is not going to really help you. So what is the gold standard test for you to know that the patient has allergic rhinitis? The gold standard test is the skin prick testing. Okay. The skin prick testing, we will demonstrate it for you in some time. We will identify what is the allergen by pricking on the skin. We'll put a small drop on the skin of the patient, and then we will just lift it up with a lancet. Lancet is a small needle. And then we will see for the classical wheal and flare response. The wheal and flare response is the redness and the swelling which will happen at the site. Okay. So that we will do a practical demonstration and show you. I want some volunteers here who have severe allergic rhinitis and who have not taken any medications for this for the past 3 or 4 days. Okay, they will be ideal candidates. So we can demonstrate on that person and all of you can see the wheal and flare response. So I will tell you how we are going to do the skin prick test in some time. So now that you have taken history, you have done a clinical examination, you need to know whether your patient has got mild allergic rhinitis or severe allergic rhinitis, or how you're going to classify him. Which basket are you going to put it? Earlier, it used to be seasonal allergic rhinitis, perennial allergic rhinitis. But nowadays, we don't use seasonal or perennial. Okay, so nowadays, the classification which is used, again, this is a neat PG question. Area guidelines. Allergic rhinitis is classified as per the allergic rhinitis and its impact on asthma guidelines. Okay, this is the accepted guidelines. So here we're classifying it as intermittent symptoms and persistent symptoms. See, intermittent is less than 4 days per week. Persistence means greater than 4 days. Mild symptoms, moderate. So mild what? Normal sleep, normal daily activities, normal work and school, no troublesome symptoms. There's a lot of emphasis given for quality of life. Okay. So if your patient is having less than 4 days and then he is able to do all this, you will say he's got intermittent mild. But if he's got like abnormal sleep, he's not able to do his daily activities, he's not going out to play, okay, problems caused at work, so then you will say it's moderate severe allergic rhinitis. Okay. So this is the area guidelines for UGs to know. Now I was telling you that the skin prick test is the gold standard. Okay. So you can prick a patient, yes, to find out what he's allergic to. But what are you going to prick him with? See, it is important for us to know that everything under the sun, including the sun, are potentially allergenic. Okay, so almost everything, every object that you name, everything in this world, including the sun above us, are potential allergens. Okay, some people can also have sun sensitivity. So with so many allergens around you, it is very difficult, no, for you to narrow down and tell, okay, what am I going to prick the patient with? So ideally, in a skin prick test, we are going to choose some allergens based on the history. We will prick 14 allergens on one forearm and 14 on the other forearm. Okay, so only 28 should be pricked at one shot. There are some people who practice this sort of pricking where they want to be like heroic prickers. They prick some 300, 400, every part of skin in the body which is available, they'll prick. You're not supposed to do that. We do only 28 allergens at a time. So how do you choose this 28 allergens? Suppose there are more allergens, you have more doubt, you call them the next day. Okay. So the common allergens for which we can get a very good result are the aeroallergens. The aeroallergens are the ones which we will be inhaling from the air. Okay. So these aeroallergens, the most common one is the house dust mite. Throughout the world, it is house dust mite. Then you also have pollen. Okay. So you have pollen in the air, then you have the dust mite, then you have animal dander, cats, dogs, everything. So all this can cause. Now you have to ask the patient certain questions like, do you get sneezing when you go to bed at night, or do you get up in the morning? Do you have sneezing? If they say yes, it's most likely to be a house dust mite. Okay. Or you should ask, do you have a lot of soft toys at home? There'll be kids with a lot of soft toys. All the soft toys will attract the house dust mite. This is how it looks. The house dust mite, this is how it looks. And it will be there in thick curtains, okay, in plush sofa sets, wherever there are carpets, okay, soft toys, all this will have the house dust mite. Now, house dust mite is one of the very, very common allergens, okay. So most of the times we are trying to cure allergic rhinitis, it is difficult to cure. We still don't know the cure for it. The best treatment for allergic rhinitis is prevention. So how are you going to prevent this house dust mite? It is very difficult. First of all, you can't see it. And it is there in your bed, it is there in your mattress, it is there in the seats that you're sitting in now. And person who is allergenic will definitely have symptoms. So what we suggest is aggressive vacuum cleaning. It is important that we do proper vacuum cleaning, take out all sorts of soft toys from the house. Okay. The mattress, if possible, we should encase it with a plastic covering. Take the bed sheet and wash it in hot water and put it for drying in sunlight so that the spores of this will decrease. It is the feces of this house dust mite which is most allergenic. Okay, it is important. So for anything to be allergenic, it has to be protein rich. So the feces will have lots of proteins. Okay, so that will cause a lot of allergic reactions. So most of us are sensitized to it. And it is also associated with all the comorbidities. Next is fungus. Fungus is one more allergen which is very commonly seen. When you have damp walls, okay, there are AC, the water is leaking from that AC, there is not adequate sunlight coming into your house, and especially in the AC filters which are not very cleaned regularly, there could be a lot of fungus deposition there. So all this also can trigger asthma. So it is very important that you reduce AC as much as possible, have bright sunlight coming home, and if you want to avoid these wet leaking walls, so you get a proper plumber. If you can't get a proper plumber, what is the next thing you can do? You can get the fungal resistant air stains, the paints. Asian Paints has got this fungal resistant paints, so you can ask them to paint your house with the fungal resistant ones. Okay. The pollen in there, I will talk a little more in depth about pollen. So the fungi and mold also are there in harvesting, cutting grass, leaf raking. So especially in the village side, you see a lot of fungal allergic rhinitis. Pets. Now there are some people who are very connected to their pets and they feel the pets are a family. So when a patient comes to you, you say, you've got dog allergy, it's better you take your dog out of the house. They'll feel very offended. For them, telling them to take, a dog out of the house is equal to like sacrilege. So they don't want to hear that. So you have to be very emotionally empathetic with them and try to understand and tell them, see, okay, there is a dog and you're allergic to it. That I know because of your skin prick test positivity. So as much as possible, try to see that the dog does not enter your bedroom. Okay, things like that. Let the dog be outdoors, and try to take it to the dog spa when there is increased hair shedding. Okay, they will have certain seasons where the dog's hair will be shedding, and that will be all over the place. And try to trim the hair. So you can tell some practical things like that. Also ask them to vacuum clean. Cats is one more thing. Okay, so cats is they're also very, especially now if you see on Instagram, there are so many anime videos about cats. Cats is the new flavor of the season. So you cannot really take out cats from the house. Okay, you have to just tell them to encourage them to see that there is a distance maintained between the humans and the animals, so that there is no conflict in between. Fine. Then another thing is high rise buildings. Okay, in Bangalore, there is so many apartment complexes coming. They're all like cubby holes. Okay, small cubby holes, and there are huge high rises. And then we see lots of patients coming from there with bad asthma, which is not at all controlled. When you take the history, they will say no, and you everything, nothing will come positive also. Then you test so many things, you don't know what they're suffering from. Then you ask them, are there any pigeons? So then they'll say, yes, doctor, there are some pigeons which come to the windowsill. So pigeons can be very, very allergenic. So also take history of pigeons. It is very important for us to take a proper history so that we know what to do the skin prick testing with. Cockroaches. Cockroaches also can be extremely allergenic, and very often we do get cockroaches. In the boys' hostel, girls' hostel, there could be lots of cockroaches and damp walls. This could also be contributing to the allergies. So dust control, regularly vacuum and clean, that is important. Pollen management, keep windows closed during high pollen seasons. Pet allergens, limit pet access to bedrooms. Mold prevention, mold is the fungi, so you can keep dehumidifiers. Chemical irritants, strong fragrances, cleaning chemicals, avoid those which can, it's more like an irritant rather than an allergen. Outdoor activities you should restrict during the pollen season. So stay indoors during high pollen seasons, shower or wash hands after returning home, keep windows and doors closed, clean surfaces and vacuum carpets regularly, wash bedding in hot water, limit pet exposure. See, all this is nice to hear, but it's very difficult for us to practically do it. Especially if you tell small children, don't go and play outside. Okay, you have to be home because you will get allergies. So it is very difficult to contain somebody with so much of energy not to go and play outside. Also, when you're coming back from a walk in the park, you can have lots of that pollen during the season on your clothes. So you come home and then everyone in the house gets triggered by it. There is something called as the hygiene hypothesis. The hygiene hypothesis states that the cleaner you are, or the cleaner the household is, okay, the more obsessed the mother is about cleanliness in the house, the more chances of getting allergic rhinitis and asthma. Okay, so that does not mean that we are as dirty as a pig, but to a certain extent, it is important to allow children to roll in the mud, to play on the grass and everything. How it is important is the first 6 years that immunity is built, and it is also the time when the body is able to recognize what is an allergen and what is safe for the body. So in the first 6 years, if the baby has been extremely protected and not allowed to go out, and the mother has got OCD about cleanliness and keeping everything very, very tidy and clean, the child is not exposed to the allergens at all. So what happens after 6 years, when the whole immune mechanism is mature, the child gets exposed to the allergens, there is suddenly the body will perceive it as something very toxic. That is when a bad allergic reaction can happen. Okay, so on a lighter side, if you're unhygienic, less chances that you will have allergies. Okay. Okay, so now coming to choosing the allergens, which I was telling you is the most important thing. So the skin prick testing will tell me what is the best allergen, what is the thing which allergen I should test for, and what my patient has allergy to. Why is this important? This has a lot of relevance because one of the best treatments for allergic rhinitis is immunotherapy. In immunotherapy, what we are trying to do is trying to see allergic rhinitis is because of IgE antibody. Okay, again for the undergraduates, allergic rhinitis is because of IgE antibodies. Now, For example, I am allergic to, say, coconut flour. Okay, I'm allergic to coconut flour, and I'm getting a very bad wheal and flare reaction, and there are a lot of coconut farms around me. So then my practitioner finds out that I'm allergic to coconut. So he will give me that coconut flour protein as a drop in my mouth. Okay, so he gives me 1 drop the first week, 2 drops the second week, 3 drops the third week. Like that, it is escalated to the maximum dose. When this maximum dose is achieved during that duration, the IgE levels will come down and the IgG goes up. Okay, so IgG is safe. It is not going to trigger an allergic reaction. It is very important for you. This is how the whole principle behind immunotherapy is. Okay, so immunotherapy is one of the hot favorite questions for NEET PG nowadays. So they will ask you a lot of questions on immunotherapy. The other thing, even for the ENT postgraduates, immunotherapy comes as a main question in your basic sciences paper. So what is the mechanism behind immunotherapy? The IgE levels in the blood will come down and the IgG increases. Okay, so this is how we are going to do immunotherapy. Now, you cannot just give immunotherapy randomly. You are giving for something, and then the patient is not even allergic to it. He is going to curse you. He will come back with symptoms. His symptoms might worsen. Plus, you're going to burn a hole in his pocket because it is very, very expensive. Okay. So, you need to identify what exactly is the allergen he is sensitive to. So, I will tell you one small story before I move on to the next slide. It was a warm spring afternoon in Melbourne, and Apollo Papadopoulos was finishing his work. But he suddenly felt sick. He had used his asthma relief medication during the day, but he called his mother that night to pick him up from a friend's place because he was feeling very unwell and he could not drive. Okay, she came there. She found her son very distressed. He was leaning on his car, short of breath, and he was not able to speak. So they called an ambulance, but before the ambulance came, Mr. Papadopoulos collapsed, and then they were unable to resuscitate him, and he died shortly. Okay, so this happened in Australia in 2016. Now, this is not when somebody died doesn't make any sense, no, in this forum to tell, okay, one person died, we don't even know who is Apollo. So the reason I'm telling you this is it was not just one death. On that day, 350 people died. Okay, and 6,000 admissions were there at once. There was a mass casualty. 6,000 admissions at once to the Melbourne Hospital Emergency Center, and the medics there could not cater to this emergency. So what exactly happened? So this is what is called as thunderstorm asthma. Okay, the phenomenon that happened on that day was thunderstorm asthma. Just imagine your emergency here. You can manage maybe 30 patients. Okay, you have a triage room and everything. But suddenly you have 6,000 patients coming in to the emergency, all of them breathless. All of them are like, very bad parameters, and then you're not able to resuscitate any one of them. And then 350 of them die also. Okay, that is catastrophic. So what happens in thunderstorm asthma? In thunderstorm asthma, on that day in Melbourne, there was a big thunderstorm. When there is a thunderstorm, the clouds will break. Okay, so you have the lightning which is coming, the clouds are breaking, raindrops are there. The raindrops attracted the allergens which were at a higher level in the atmosphere. Okay, the allergens, like it could be carbon dioxide, nitrogen dioxide, sulfur dioxide, exhaust fumes. It could be the hay. It was the hay fever season because they had cut the grass, so there's a lot of pollen in the air. So all these pollen got attached to all those small particles in the air. So once it got attached to those raindrops, it became heavier. When it became heavier, it came to the level of my breathing level. Okay, so I started inhaling this. Now I was already sensitized to pollen, and suddenly, because there was so much of a pollen load coming into my lungs, there was a severe allergic reaction, anaphylactic reaction, and the patient had asthma. Okay, so Melbourne is known as the global hotspot for thunderstorm asthma because of grass grown in northern parts of Victoria. So on that hot, windy day, the temperature in the city hit 35 degrees. Then there was a change in thunderstorms came. Okay, so the ryegrass pollen, which was swept in from the countryside, it became saturated with water. The pollen burst into very fine particles and it caused the asthma like symptoms. Okay. So there were like 6,000 people at once rushed to the emergency. So intact pollen grains are big. Okay. But for them to reach the lower airway, how much time do I have? Just let me know. So intact pollen grains are large and they can reach the lower airways only if it is smaller size. Okay. So when there is a osmotic shock, the pollen will swell and then it becomes smaller, it fragments and it goes into the lower airways. So developing storms will carry all these intact pollen grains into the clouds, okay, and then they rupture and release highly allergenic particles. So from here they travel towards the ground to our breathing level and it enters into our lungs. So why did I tell you about this thunderstorm asthma? Now, one of the common allergens that we see around us is because of pollen allergy. Okay. So there are a lot of pollens which are allergenic to us. We don't know what. We have to also decide when we are doing the skin prick testing for immunotherapy, which pollen we are going to select. So the pollens are usually, you have the BBMP in Bangalore, or you have the Tumakuru, the municipal corporation here, who will be planting all the roadside trees. This avenue trees they would have planted. So you have these yellow flowers coming in April, you have the red flowers coming, and it looks so beautiful. The whole place, it looks like, if you go in front of Vidhan Sauda also, there are so many flowering trees, Kaban Park, Lal Bagh, everything. It is the same tree which is there, because it is planted by the corporation. So this pollen, every pollen has got around 150 kilometer radius. Okay. So from Bangalore, it can also come to Tumakuru. Fine. It has around 150 kilometer radius. There are two types of pollen. One is anemophilic, which will come through the wind. The other is entomophilic. Entomophilic means insects will sit on that pollen and carry it from one place to another. These entomophilic pollen are usually seen in the bright colored flowers. They will attract all the insects. Insects will go and sit on them like bees and all that, and they transmit. That's how pollination occurs. The anemophilic ones are dispersed in the wind. Anemo is wind. Okay, they're dispersed in the wind. These wind pollens can be dangerous in people who are, sensitive to it. And these pollens are not there throughout the year. They're there during certain seasons, which we call as a peak season for the pollen to appear. So if you find the patient has got, say, for example, grass pollen sensitivity, you tell him, okay, this grass pollen is going to be active at this time. It is going to peak in the month of June and July. So June and July, you be careful, wear a mask. And if you're going to the park for a walk, you go after 8 in the morning or before 4 in the evening, because that is 4 to 6 and 6 to 8 in the morning are the peak pollen seasons. Okay. So when they're going to start the allergy clinic in the ENT department here, they have to order the kit for all the allergens they're going to test for the patient who comes. This man who will come with the kit, the company person, he will tell, doctor, I have some 1,000 allergens. Which one do you want? If you take 100 allergens, this is the cost. If you take 200, this is the cost. If you take 1,000, this much is the cost. Now, obviously, all of us will have a budget. And in that budget, we want to get the best deal, correct? So we have to know which one to choose. To know which one to choose, we should know which is the pollen, no? Sometimes they will give you pollen from maple leaf tree. They will give you pollen from pine trees. Okay, they will give you something from cedar wood, redwood. Why? Because earlier we used to get the pollen from US. And none of those trees are there in India, in southern part of India. Maybe in Kashmir you will find it, but here you will not find any of those coniferous type of trees. So you're investing on something and you're not able to test, and all your pollen tests are coming negative. So it is important for us to know what is the pollen circulating in our area. For this, we do what is called as a pollen calendar. Okay. So this pollen calendar is very, very important. When I was in Belgium and I was doing my fellowship, and even when I was in the US, every day in the news, you have TV9, all these channels, like how it comes. TV9 down, some criminal thing will be coming. This person hit that person. This one happened. That person is exposed. Something like that. There, such things won't come in the subtitles in the lower part of the news thing panel. They will instead be telling pollen count of this tree is so high. Pollen count of this tree is less this day. So when I was in the US long back, when I was just finished my MBBS, I used to wonder why they're so obsessed about this pollen counts. I only understood later on that it plays a very important role for patients who are allergenic. Some people have such severe allergies, like there was one person in the Central Park in New York. Okay, he just finished his run. He sat down in the park, and then there was a man who came also and sat next to him, and he just opened one peanut packet. He just opened the peanut packet, and that person who was a runner next to him just collapsed and died. Okay, sometimes the allergies can be so severe. So they have a very regular, and it was a big sensation at that time in Central Park, New York, when this incident happened. Okay, so in US and all, they have what is called as an EpiPen. EpiPen is epinephrine, adrenaline injection. So a person who is, they have a license to carry an EpiPen, they carry it everywhere because they can have an anaphylactic reaction anywhere. So they will self-inject with that EpiPen. In India, it is not there. It is not yet approved by the government. Also, sometimes it is scary, if you don't like somebody and you poke them with the pen, they can suddenly have tachycardia and vasoconstriction and all that. So it is dangerous. So, but there it is accepted. There's a lot of move to get it into India, but still we're not successful. So why I'm telling you this is, so pollen, we need to first identify what is the pollen in the air and test, so that we are not buying the wrong pollen from the company. Okay, the company person also is here. When he comes in the later session and shows you the skin prick testing, he's going to tell you the list of pollens he has. So palynology is the study of pollens. This is how we make a pollen calendar. So each person who's starting a allergy clinic should have a basic idea of the pollen in his area and try to make a pollen calendar. Okay. So how do we do this pollen calendar? So there are several ways it is created. One is the sample collection, then the microscopic analysis, then we do the data compilation, graphical representation, all these things. I'm not going to go into things which is not going to be useful for you. Only those which you can apply in practice, I will tell. Okay. So it is important for allergy sufferers, for healthcare professionals, for environmental studies. So this is how we collect the pollen. See, this is called as the Burkhardt sampler. It's one big thing. You will find it so, you will say, okay, I'm not going to make my pollen calendar. It looks too complicated. See, it looks too complicated, no? Then there's this rotorod sampler. This also is looking very complicated. You don't want to do any pollen calendar with this. So I will teach you how you do your own pollen calendar. This is a do-it-yourself aeropalynological study wherein you can make your own pollen calendar very, very simple way. So this was a project I did which was funded by the Indian Council of Medical Research. So they gave around quite a good sum, around 30-40 lakhs they gave for doing this project. So this was, I was able to employ 2 people for this project. Who were pure botanists. Okay, the botanists came and I paid them. They were there for 3 years. For 3 years, we studied the pollen graph. Okay, then now it is readily available, but it's not very accurate. It is important that you can do. You can also do this. It's very simple. So you can see there's a, this was a glass test tube. Very simple. Okay, there's a glass test tube here, and we put a Vaseline tape around this glass rod. Okay, that's all. So where we did this, we did it in the highest point of St. John's. That was where I was working before. So in St. John's Medical College, highest point of the terrace, we did one. I also wanted to study what happens in the rural areas and the allergic profile there. So we put up a pollen trap in Muglur, where our primary health center is there. So there in the villages also, we put one pollen trap. So initially the botanists came, and every day I was very eager, also the stress is there. ICMR has paid me money. I have to generate results. But every day these botanists are coming and saying, no pollen, no pollen. I said, how can it be possible? I've done so much of research. I've read so much, but we're not finding any pollen at all. Then we just took the CCTV footage. The botanist told me it is like some smudge marks are there, but there are no pollen. So when we took the CCTV footage and we saw that, a lot of monkeys which were very excited seeing this new thing which had come up on the terrace, and every day they would go and fiddle with it. Okay, so we had to do something about it. So that is when we constructed a cage, so the monkeys will not go fiddle on it. And then we were able to collect the pollens. The air velocity decreased, but we had to do it to prevent monkeys coming. So now this is what we got. Okay, So these are very interesting things that we see. This is all of you will know. Parthenium, Congress. Okay, Congress grass, which is not native to India, was gifted by the British to us. It came all the way from South America, and now it is there in every empty field. So this is how it looks, the pollen here. Okay, next one is Cocos nucifera, coconut. Okay, this is how the pollen looks. This is lily. This is how it looks. Okay, like this, we started charting the pollen. This is the African tulip tree. Okay, this is a very nice red color flowers, bright red, and they have boat shaped structures in which there are anemophilic pollens. The parakeets also come a lot to this tree. So this is the African tulip tree. This is also planted by the BBMP. I'm sure you would have seen this. Plus this yellow flowers. Okay, so this is then you also have Caesalpinia, yellow flowers. In April, May, you'll see this. Then this is corn dog grass. This is like in all the marshy areas, whenever some small water body is there, you have a lot of weeds growing. Then you also have this corn dog grass. So this is how the pollen looks. So this is grass pollen. This is again Asteraceae and Parthenium. Okay. So this we identified the pollen, and now see we have made a graph, which where it is peaking, where it comes down, where it is peaking, where it comes down. So we were able to, if we are doing the skin prick testing, and for example, the patient has allergy to Liliaceae, which we'll say, okay, fine, you be careful in the month of October. Don't go out. Okay, the white lilies are coming September, October. That time you be careful. Don't do too much weeding or wear a mask if you're walking in a park. Fine. This is how we do it. So this is the urban pollen calendar. Okay, so you can see Caesalpinia, then you have Fabaceae, so Liliaceae. These are all common things which you would have seen because it is our corporation only planting all this, and we keep it as garden plants also. Then we also did a rural calendar. Then we also studied the trees which are there. So we had eucalyptus tree. Okay, eucalyptus pollen was there. So you will see, okay, there's no eucalyptus around next to me, how these things are coming. But like I told you, they can travel 150 kilometers. So it will be in the air, and a person who's sensitized will get exposed, allergic to it. Then these are some statistics we did for the wheat pollen and the sensitivities, tree pollen, and how it is in different places. Okay, this is all part of the project, so I had to give the statistical report for them. We also checked the fungal spores. This is Rhizopus, mucormycosis, all of you know. This is Rhizopus, okay? And this Helminthosporium and Alternaria, okay? So these are the fungal spores. Then we had Penicillium, Alternaria, Rhizopus, okay? This is in the rural. Penicillium was very, very common. In the villages and all where the fields are there, no? Penicillium is very common. Then after we chose the allergens based on the history, whether there are cats, dogs, everything in the house, do you have damp walls? Do you get allergies when you go into the bedroom? Okay, do you start sneezing at that time? And also, what are the plants around your area? So then we were able to do the skin prick testing, fine? So now that you've done skin prick testing, now you know everything, okay? So far, we have taken history, we have identified the cause of allergen, we have done all the diagnostic tests. Now what? Next what? So how are we going to treat allergic rhinitis? There is a particular pyramid approach to treating allergic rhinitis, which is called as per the area guidelines. So you can see that it's mild intermittent, moderate severe intermittent, mild persistent, moderate severe persistent, based on what category your patient falls into. Always start with basic. See, first thing you have to tell is avoid allergen. Avoiding allergen is easier said than done, but as much as possible, if you identify a culprit allergen, ask them to avoid. Then you can start with antihistamines. Then leukotriene receptor antagonists, okay? So that will help to suppress the inflammation with leukotrienes. Then you have the oral or non-sedative H1 blockers. Now, Bilastine is the new one. For students who are studying for exams, you can take Bilastine. It will not make you sleepy, okay? And then intranasal steroids. So intranasal steroids act very well. They act locally, and then they do not suppress the hypothalamo-pituitary axis. So they are very safe and can be given. So immunotherapy is another important thing. So we will be telling you how we will, I think Dr. Puneet will be speaking about immunotherapy. He will tell you how we are going to give the immunotherapy for patients once we have identified the allergens. So to summarize, allergic rhinitis and asthma go hand in hand. So always important that you ask symptoms of a wheeze. Many times they will not even tell you because they feel that it's a social taboo, okay? And it is important for you to know that allergic rhinitis and asthma will affect the young patients, the productive age group, okay? So their quality of life will be affected, their livelihood will be affected. The top aeroallergens will be house dust mite, pollen, even fungi and animals, insects, okay? 5 categories are there. It is very important you make your own pollen calendar if you're starting your allergy practice, so you know what to test in the patient. And specific IgE testing and sublingual immunotherapy. So this is the way for precision medicine, where you're tailor making and you're telling the patient, okay, fine, this is what you have to take. It's not like some blanket prescription that you're giving. It is very focused, okay? So in Europe and all, now it is all about precision medicine. So this is me when I was in Belgium. So I did a fellowship with the European Academy of Allergy and Clinical Immunology. This is me here. This is my mentor, Professor Peter Hellings. I was there for 6 months, and we also had to do a lot of lab work. So I worked on mice. I was studying the nasal epithelial barrier and to see how the nasal epithelial barrier is a very, very strong barrier. It will not allow things from outside to go inside. Okay, so it acts as a very good policeman. So if there is a leak, the staphylococcus toxins, no, that creates a leak in this barrier. So as a result of which all the toxins, allergens, everything can go inside. So there's a lot of research on it to seal that barrier. And this is the ICMR project, and I did it with Professor Ruby Pavankar, and she's the president of the World Allergy Organization. So thank you very much. Thanks for the patient listening.
Thank you, ma'am. That was a wonderfully detailed and engaging presentation on aeroallergens. Your clarity on the topic has given us much to reflect upon. I now request Dr. Rangaswamy sir from the Department of Community Medicine to felicitate our chairpersons. Moving on, I now call upon Dr. Manju sir to introduce to us all our next speaker, Dr. Puneet K. Nagendra sir. Over to you, sir.
Good morning, all. It's my privilege to welcome our esteemed speaker, Dr. Puneet sir. Full name is Dr. Puneet K. Nagendra, a distinguished respiratory allergist and pulmonologist, currently serving at Bangalore Allergy Center and also as assistant professor at Department of Respiratory Medicine at the Anand Sagar University, Bangalore. Dr. Puneet has an impressive academic journey. He did his MBBS, DTCD and DNB in respiratory medicine, and also fellowship in allergy and allergen-specific immunotherapy from RGHS University, and fellowship in palliative care medicine, and diploma in counseling skills. His clinical experiences span across premium institutes such as Sri Ramchandra Medical College, Chennai, Bhagwan Mahavir Jain Hospital, Bangalore, and St. Muir Medical Center, California, USA. He has also been trained in the integrated approach to disease management at Vyasa Yoga University, Bangalore. At professional front, he is the executive director of BACME, which involves actively in training future medical counselors. He's been instrumental in organizing impactful academic programs, including Karnataka Pulmonary Association Open Learn and Expert Opinion webinars. Uh, His research work includes many. Distinguished ones are like clinical trials on Bluetooth stethoscope and novel herbal preparations for prevention of ET-tendinous hepatotoxicity. Beyond medicine, Dr. Puneet is deeply engaged in community services. As the president of Rotary Bangalore Reach Out 24-25, he has been uh, championing projects in disease prevention and treatment and water and sanitation, and also education literacy activities. With his unique blend of clinical expertise, academic leadership, research innovation, and community service, Dr. Puneet truly embodies the spirit of physician, educator, and social leader. Please join me in warmly welcoming Dr. Puneet K. Nagendra to the session. Welcome, you, sir.
Now, let us move on to understand about the allergy menu, peanut, prawns, and chaos. Our speaker for the session is Dr. Puneet K. Nagendra, sir. The session will be chaired by Dr. Munishwara, sir, Senior Consultant ENT Surgeon at Ganadhal ENT Clinic, Tumakuru. I also request Dr. Maunish, sir, Professor Department of Pediatrics, to chair the session.
Good morning, all. I'm Dr. Puneet. I see a mixed crowd here, trying to make it as simple as possible and as practically also to give away some of the tips which we have learned through our practice of allergy. So I'm glad we have a very great ENT surgeon who has interest in allergy and he's practicing allergy. I'm thankful for him to be on as a chairperson, and Dr. Munishwar, and also you are a pediatrician, right? Yeah. Thank you.
I just want to tell a few words about Dr. Puneet. I know him for, I think, past 10 to 15 years. He has got a lot of interest in allergy and especially pulmonology. And not only that, he's also into this other activities, like as he was introduced. He's in a Rotary Club and he does a lot of activities in the yoga. So he's a fond of yoga. So you can look out for him for any information on allergy, pulmonology information, anytime of the day. And I am, because of Puneet, actually, I came here all the way and spending time. So I'm very happy to introduce also Puneet, and welcome to Tumakuru and Sridevi Medical College.
Thank you, sir. I'm also glad that, I heard today is your state END conference and you have organized a workshop here. We see a lot of ENT people here as well. Okay, we'll start the session. So I just want to bring this small note. The dog is very unhappy seeing this burger. That reason also the same thing with a lot of emotions with the food, right? So we want to eat that particular food, but then that food is not very comfortable after we consume. So that is what is food allergy about. We'll see what greetings from Dhanand Sagar University. We'll see what is the burden of food allergy, definitions, how do we evaluate food allergy, diagnosis, and then we'll see what are the treatment options. Let's start with some small case. It's a 2-year-old boy, and the boy had recurrent episodes of vomiting, urticaria, wheezing, and which would start within 30 minutes of consuming milk. Now, the mother also recalls the child having facial swelling and difficulty in breathing. with a cup of milk. Now, the child tolerates soy-based formula but avoids all dairy products. So, many of you would have also gone through your childhood with similar symptoms, and families are uncertain whether it's a true allergy or it is a lactose intolerance. Now, the discussion is all about the family wants to know whether it is IG mediated allergy, I mean, or what steps they want to undertake to know what is this kind of allergy. So let's see what is that, how we can answer these questions. So the burden of food allergy is about 10%, up to 10% in children and 5 to 10% in adults. It usually impacts the health because the moment you see that food is causing allergy, you want to refrain from that food and you're nutritionally deprived. That's not good, is it not? So it would reduce your quality of life as well. But if some allergy and some food is really causing allergy, it would really give you a fatal reaction in the form of an anaphylaxis. It would give a psychological burden because frequently you're going under anaphylaxis and treatment for allergy. So it is important to have accurate diagnosis and avoid unnecessary restriction, because nowadays we see anyone having food allergy would go a panel of tests, and then there is a list of food ingredients which say, okay, don't eat chilies, don't eat tomatoes, don't eat cheese, don't eat chocolate. So many things list up. So they're all something which have to be deciphered. We'll just see what it is. So we have two terminologies. One is food hypersensitivity, which means any food you consume, there is a response to the food, but then that response is not IgE mediated, or it is not immunologically mediated. So it's just an hypersensitivity reaction. But if some food, when consumed, causes an immune mounted response, then it is called as a food allergy. So either it can be an IgE mediated or a non-IgE mediated. So we can see an umbrella of conditions when it comes to non-IG mediated. So we have something called as contact dermatitis. We have food protein induced enterocolitis syndrome, very commonly seen with seafood. Then we have food protein induced allergic proctitis and proctocolitis, and food protein induced enteropathy, dermatitis herpetiformis, and Hainer syndrome. Now, the IgE and non-IgE mediated food allergy, it can be in the form of eosinophilic esophagitis, where it's very common. Then we have asthma exacerbation. Then we have enteritis and gastritis. So these are some of the common things. I just want you to understand food is causing so many problems in the body. So usually it involves all the systems. Okay, so there's a list of symptoms, but any symptom can fit into the allergy. But most commonly we see skin, urticaria, we see vomiting, nausea, cramps. We have neurological symptoms, even loss of consciousness, syncope, also may be quite common. So what are the other things which may mimic food allergy? So it should also be important that we have to diagnose food allergy appropriately, because food is what we are living for. We are earning our money to live and have food, and food is something which allows us to have some everyday living. So when all these things are there related to food, so do we really have to restrict our food intake just because a panel of tests or some one incident has caused this kind of reaction? So it's important to rule out all these disorders. So especially the atopic eczema, the toxic events, or the IBS. It may be as simple as GERD. Okay. So it's important to rule out all these diagnoses before you label some patient as a food allergy. So let's see what all we can do. History is very important. So we start with a clinical history. A detailed history will always guide us to get the person having food allergy. So the second important thing will be the test investigations, which are the skin prick test, which madam has highlighted, and also certain immunological tests, IG mediated, IG specific food allergens, and also basophil activation tests. These are very important tests to diagnose any allergy. Now, this becomes a kind of predictable table. So, just we have any kind of scoring systems with the history, and to diagnose, especially the most commonly used is the DVT and the pulmonary embolism score in pulmonology. So, similarly, from the history, what is the probability of allergy, and from the test, what is the probability of allergy? So, if the probability of history from whatever I see, I think, yeah, okay. So we can see the high probability of allergy from the history and from the test. Then there is likely to be allergy. Probability of allergy is intermediate, and when the history is intermediate, but the test is also intermediate. So when the probability from the history is low, so the usually the test also will be low. So, what are the history diagnostic? What do you call recommendations from for diagnosis of food allergy? Clinical history, it has a very strong recommendation. Clinical history is very important for the diagnosis of food allergy. In the diagnostic test, we have patients with IgE. We get this list. It also has a strong recommendation provided the oh, oh. So provided the IG specific panel is done and then correlated with the history. Then we have the component result diagnosis, wherein the allergens will have certain allergen components against these antibodies would be detected. So this is the component result diagnosis, that is also have a strong recommendation. In patients with IG mediated peanut, especially the peanut, sesame, and the milk, we have something called as basophil activation test. That is also conditional. This is more of research value than of clinical value. Whereas in case of IG mediated, IgG and IgG subclass, this is also a good indicator of allergy. And then we have um, food allergy in children, so which we have to reassess over a period of time, because in children it is very important to understand over a period of as they grow, maybe around 5 or 6 years, most of the food allergies will come down. So that assessment has to be done in children. And oral food challenge test, which is the most diagnostic test for the food allergy, is the strong recommendation. But there is something other than that called the double blind placebo controlled food challenge test. So this particular test is for research purpose. Okay, so it is usually a conditional thing. Now, history is very important. We have to ask what is the age of onset, then what is the timing of the food that has been ingested, and what is the symptom when it has occurred. When what has been the frequency of the symptoms? Whenever you, is it all the time when you take consume food, and it is occurring every time you consume? And what are the cofactors? Especially there's an entity called as food induced exercise induced anaphylaxis. So it is very important if the person has anaphylaxis following food consumption and there is an exercise. So we have now very fancy trends of doing gym throughout 24 hours. So this exercise also is causing lot of other diseases in the body. Dietary history, I said we have to have a food diary. For anyone having food allergy, it is always important to have a food diary which will enlist what are the vegetables, what are the fruits, what are the oils, what are the sweets, what are the fried foods, what are the processed foods which have caused their allergy. It is very important to enlist. So food allergy, the primary focus is the allergic reactions, and there's something called as pollen food syndrome. Now this is very interesting because during certain seasons and because of the cross reactivity of the allergen, this concept madam has already told. So during that period, the person will have allergy symptoms to certain foods. So it's very interesting to know this. So this is in gross. During we have this spring, we have these foods. In summer, we have these fruits, and then in fall, we have these vegetables, which cause certain allergies. That is because of the pollens. Okay, so the birch pollen can cross react to so many food allergens. That is apple, peach, plum, pear. Of course, many of them are not native to India, but then since we have paucity of data related to Indian food allergens, so this certain things we can consider them as, because nowadays many fruits are imported. So we can see all these allergies to food during when they have confirmed allergy to birch pollen. Then we have ragweed. Whenever there is a ragweed pollen, then patients may have cross reactivity to watermelon, zucchini, cucumber, and banana. Okay, so this is one such thing. Then we have mugwort, then orchard and timothy. Of course, these are certain pollens which are very common in America. So the diagnostic tests are the skin prick test, then the serum specific IgE, then the basophil activation test. Here in basophil activation test, we usually detect the presence of the activated basophils, which is CD63 plus. When there are more than 5% of these cells in that particular sample of the patient who is undergoing this test, it is considered as positive. It is always important to understand this IgG and IgG4 are not a very good test for a diagnosis or for the follow-up. Then we have the oral food challenge test. I said this is something which is very important for the diagnosis of food allergy. Here, any patient is subjected, or any patient having symptoms of food allergy is subjected to the consumption of food which they are which is in query for food allergy, and they, within 2 hours of consumption, they generally have this tingling, they have this food abdominal cramps and other allergy symptoms. So this is a diagnostic of food allergy. But safety is an issue because they may develop anaphylaxis. So it is important that it has to be done in a controlled environment, especially the hospital settings. So the indications will be generally a patient coming with food allergy suspect. Certain tests are also positive, and then you want to confirm, you subject them to the foods. So ideally, they also have to bring the food which they have to, which are they are in kind of doubtful. So this is one kind of food challenge test. So what happened to this kid? How did we treat? How do we go about for this patient? So we know that certain markers from these history and from knowledge what we gain. So the person is definitely suffering from milk allergy. So strict avoidance is something very important for especially children, because once you confirm food allergy, even a small a few mLs of food or few milligrams of food may also cause anaphylactic reaction in children. So that may happen because most of the food in every one of our house is unattended. I mean, it's not locked, it's open lying everywhere, especially the nuts, the milk, and things like that. It's always available at handy, right? So it's very important to strictly avoid this food. That's not only the thing, but then there are many modalities of treatment available. One is the immunotherapy. Okay, so currently commercially, peanut we get oral immunotherapy. We also get epicutaneous immunotherapy for peanut. However, milk is nothing commercially available. However, we can dilute the milk and then keep giving to the child, and over a period of time it can get desensitized to the milk allergen. But here it's very important that again it has to be observed, it has to be carefully administered to the parents who can really do it very well. Okay, So it's again dietary interventions. It's important to understand most of the food allergy can resolve, especially the cow milk, egg, wheat, and soy allergy. So it can just about 90%, up to 90% of children by the age of 6 years, they just get away with this food allergy. Whereas in case of cow allergy or egg allergy, 30% of the children they get away with it. And sesame seeds, which is less common in south, but however it is used I mean, the oil is not commonly used, but however sesame seeds are used in most of our preparations. Fish allergy is kind of many of the youngsters now want to eat seafood. So fish allergies and the seafood allergies definitely would wane away by the age of 5 or 6 years. But does persist for many of the adults. In case of cow milk allergy, it is important that um, the pediatrician or the parents switch over to the hypoallergenic milk. So there is nothing called hypoallergenic milk available, but then when some formulation or some milk which is most tolerable by most of the population, up to 90% of population, then we can put it as hypoallergenic milk. And then we also have certain formula milks which are about I mean, they are labeled, I mean, the powders are labeled as formula milks for milk allergy. These has no cow proteins. And breastfeeding mothers need not worry about any food consumption because it would not affect the breast milk content. Then allergen immunotherapy for food allergy, the EACI, that is the European Allergy and Asthma Congress in 2023, they strongly recommended peanut oral immunotherapy in selected children and moderate recommendations for peanut epicutaneous immunotherapy. So the indications what they have given in their guidelines is any person with a proven, so that is specific IgE mediated panel which is showing positivity for food allergen and also persistent allergic symptoms. So I said the food diary is important, through which we'll be able to get through the events whenever the person had food allergy. Then the contraindications are usually uncontrolled asthma. So any patient undergoing immunotherapy, it is very important that their asthma is well under control. It is important to do a pulmonary function test. So the baseline value, we would put it as more than 70% of FEV1 is a candidate who has to undergo immunotherapy. And especially pregnancy, we are not going to start immunotherapy. It's very important to consider immunotherapy and confirm that any woman in the childbearing age group should not be started with immunotherapy. So it is important to understand immunotherapy cannot be started by everyone because it's not just a drug which is available over the counter. It is to be given only by people who have been trained in practice of immunotherapy, because anaphylaxis and other reactions are very, I mean, fatal. So it has to be monitored and then only be administered. So the recommendations for the task force, the GALAN, that is the Global Allergy and Asthma European Network, has given certain recommendations for food allergy. They say that until and unless a food has been proven to be allergic, try not to suggest avoid this food, because as I said earlier, this particular food may deprive that person of certain minerals, certain proteins, which is going to have a long-term effect. Then any person who has milk allergy, hypoallergenic milk formulation is something which we have to suggest. In case of immunotherapy, in case of peanuts, oral immunotherapy is highly recommended. In case of egg and cow milk allergy, oral immunotherapy has a moderate recommendation. Biologic therapy is the current trend, and that is what is the recent advances we see. Omalizumab, a time-tested molecule against the against the Ig antibodies, and atokimab, which is anti-IL-33, and dupilumab is still under study. Not many recommendations or evidence are available. So prevention is the something which we have to depend upon. So we need to see that if the person is also having coexisting asthma, it is very important to control this asthma. So it's also important that we have to train these people that exercise and food should not be together. Okay, so many people have the habit of consuming food and then going for an exercise. Walk is allowed, but not an rigorous exercise. So consumption of NSAIDs and paracetamol. So any amount of NSAIDs also induces many of the hypersensitivity reactions. It's important to get into the aspect of that. So the perspectives or the barriers to the management of food allergy is limited. Centers are practicing food allergy, and then few people are only knowing how to address this food allergy. The cost of food allergy management is very high just because the person who has to sit with that particular patient has to spend a long time, and the kind of foods they have to consume, if they have to resort to certain non-allergic foods, it's also expensive. And most of the foods in India are still not labeled for allergenic um, contents. So the response to allergen immunotherapy, the research is still low. We are yet to get many of the studies in that aspect. So many biologics have not been used for food allergy. These are the research gaps. So it's the message I would give to this crowd is to see that have spent an enough time with that patient who is saying that I have food allergy, get through the history and confirm with certain specific diagnostic tests, avoid or inspect certain tests which they bring with, whether it is a validated test or whether it is an invalidated test. It's always important to spend that spend time with that patient. We have a team of people who are dietitians, psychologists, nurses, to spend time with this patient. And then it's always important to involve the families, because the family should know what the person should eat or should not eat. And then it's important to have a quality of life with existing food allergy. Regular assessment is important in children because the food allergies keep changing. So finally, with the case, as the child grew up, he could consume the cow's milk. So that's the moral of the story. Thank you.
Thank you, Puneet. Thank you, Puneet. Actually, in fact, in my clinical practice, I have taken many times help of Dr. Puneet, especially food allergy. So one thing what I do regarding food allergy is every patient will ask what food to avoid, what to eat. This is a common question in clinical practice. Whether you're done a ear surgery, whether you're done a nose surgery, whether you're a regular patient, they'll ask. So what I do is I ask the patient to take every food, snap of the photo can be taken. They can keep it for a month or so. They can store the photos, and the same symptoms come up every time they eat a brinjal preparation and they're getting the symptoms. I think we can use that data and tell that there's a problem with brinjal or tomato, whatever like that. That's what I do, one thing. And it's a very important topic, food allergy. And I think still we are in that lot of darkness. Still it is existent. Lot of research is required. And I think many have got food allergy, and which we yet to know. I think it needs a lot of inputs required from many people. Thank you.
Thank you, sir, for elaborate talk. As a pediatrician, we normally see a lot of patients coming with diarrhea, loose motion after consuming certain foods, and we treat most of the time. Not only pediatrician, even outside practitioners treat them with antibiotics and send them off. So, there, as you said, there's a lot of research gap in this field. We need to address. We need to counsel. And as a one more thing, as a pediatrician, after many patients comes to us with, like after having a milk cake, gets a lot of cough and cold, and even bloating of the abdomen. Should we avoid or not? These are the area where we need to focus much also. Thank you for elaborate talks.
Yes, sir. As you said, most of the times the pediatrician tend to resort to antibiotics. I wish and convey the message to this forum that please restrict the use of antibiotics. That is where more and more allergies are flaring up. The more you put in or pump in an antibiotic into a human body, there is dysbiosis. The microbiome in the gut and the microbiome in every organ is just getting distorted. So that is the cause for allergy. So thanks for the point. And then any other questions or anything from the audience? We'll close the session. Any comments, closing comments?
You also do some blood test to find out the food allergies?
Correct, sir. So we have specific IG which is followed.
Yeah.
So, but then this specific IG report has to be kind of concluded with the history, not just read through the specific IG report and say you would have not had fish at all, and I do a test, and you are found allergic to fish. That may be a predictor that you may be allergic to fish, provided you consume fish and you had a response.
Correct.
So it is always important. Clinical history is the only clinching point for the diagnosis in any condition, for that matter. I feel
The test report and the history should correlate.
correlate.
Yeah,
Correct.
because many patients now bring the
Correct.
reports of the allergy test reports. So
One reason is cross reactivity.
Cross
One major reason is cross reactivity. We still don't have proteins which are specific to specific allergens. So there is always a cross reactivity. Immunoglobulins are not there for every protein. So they share some antibodies. So
yes.
that
With respect
concept.
to food allergy, I want to tell you a story. There was one patient who used to develop some skin problems. They went to many doctors. Then no one could able to identify the reason, and she suffered for a long time. And then somebody told it may. They later they found it was peanut allergy, and they avoided the groundnut oil in cooking in their house, and she became all right. So then the whole problem was solved. It was simple problem, but no one could able to identify it was the groundnut oil was a culprit. So that means it is not only nuts preparations which go in any manner, they can create the problem for the patient.
Correct.
Thank you, sir.
Thank you, sir. Thank you.
Thank you, sir, for delivering such a detailed and enlightening lecture on food allergens. We are grateful for your time and expertise. May I take this opportunity to call upon Dr. Swaroop Dev, sir, Professor, Department of ENT, Siddhartha Medical College, to felicitate our chairpersons. With that, we will begin the inauguration and formally start today's program. We would like to invite all the dignitaries on the dais. Let us start this program with a prayerful melody. I invite our enthusiastic intern, Dr. Abhishek B. Acharya, to come forward and render the invocation song.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देवा सर्वकार्येषु सर्वदा मामवतु श्री सरस्वती मामवतु श्री सरस्वती मामवतु श्री सरस्वती मामवतु श्री सरस्वती कामकोटिपीठनिवासिनी मामवतु श्री सरस्वती कोमलकर सरोजधृतवीण कोमलकर सरोजधृतवीण सीमातीर्थवरवाग्भूषण मामवतु श्री सरस्वती राजाधिराज पूजित चरण राजीवनयन रमणीय वदन राजाधिराज पूजित चरण राजीवनयन रमणीय वदन सृजन मनोरथ पूर्ण चतुर निजಗಳ ಶೋಭಿತ ಮಣಿಮಯ ಹಾರ ಸೃಜನ ಮನೋರಥ ಪೂರ್ಣ ಚತುರ ನಿಜಗಳ ಶೋಭಿತ ಮಣಿಮಯ ಹಾರ ಅಜಭವ ವಂದಿತ ವಾಸುದೇವ ಚರಣಾರ್ಪಿತ ಸಕಲ ವೇದ ಸಾರ ಅಜಭವ ವಂದಿತ ವಾಸುದೇವ ಚರಣಾರ್ಪಿತ ಸಕಲ ವೇದ ಸಾರ ಮಾಮವತು ಶ್ರೀ ಸರಸ್ವತಿ कामकोटिपीठनिवासिनी मामवतु श्री सरस्वती सरस्वती सरस्वती.
Thank you, Dr. Abhishek, for setting such a serene and positive tone for today's program. Moving forward, I invite Dr. Soumya Santosh, ma'am, Assistant Professor, Department of ENT, to deliver the welcome address. Over to you, ma'am.
Good morning, respected dignitaries, esteemed faculty members, and dear colleagues. It gives me immense pleasure to welcome you all for today's CME on Allergy Unveiled, all about understanding, management, and prevention of a growing health concern. On behalf of organizing committee, I take this opportunity to welcome you all. First and foremost, I would like to welcome our beloved chairman, sir, Dr. M.R. Hulinaikar, sir, whose presence inspires us and his vision continues to guide the medical fraternity. Now, I would like to welcome respected Medical Director Dr. Raman M. Hulinaikar, sir, a leader in advancing healthcare and academic excellence. Welcome, sir. Now, I would extend my warm welcome to Sri M.S. Patil, sir, Director, HR and IT, Sridevi Charitable Trust, a pillar of support to this institution whose encouragement makes us such programs possible. Now, I would cordially welcome Dr. Lavanya Raman, ma'am, in her absentia, Trustee Sridevi Charitable Trust, whose constant encouragement and leadership have been instrumental in bringing this CMA to life. And a cheerful welcome to Dr. Mohan Kumar, sir, our beloved medical superintendent. We are pleased to have you here, sir. Welcome, sir. I'm glad to welcome our beloved HOD, sir, Dr. K.L. Shivkumar, sir, whose able guidance leads us every day to think different. Now, I would like to welcome Dr. Manju, HOD, Department of Pulmonology, and one of the organizing chairpersons of today's event. Welcome, sir. I am delighted to welcome our speaker, Dr. Soumya MS, a dynamic practitioner, renowned academician, and respected teacher who has guided generations of medical students with wisdom and compassion. With equal honor, I welcome our speaker, Dr. Puneet K. Nagendra, sir, a distinguished scholar, dedicated healer, and an accomplished researcher whose contribution in the field of respiratory medicine and allergy continue to inspire innovative approaches. And I would extend my warm welcome to all our chairpersons of today's session, Dr. Narayan Swami, sir, Dr. Virupaksha, sir, Dr. Munishwar, sir, Dr. Maunesh, sir, and Dr. Shivkumar, sir. All your presence in the event will forever remain with us and will be cherished. And at last, I would like to welcome all our enthusiastic delegates to this great event. May today's deliberations be insightful, engaging, and fruitful. Together, let us create lasting memories and impactful outcomes. Thank you.
Thank you, ma'am, for your warm welcome address. As light dispels darkness and knowledge conquers ignorance, let us begin today's gathering with the sacred tradition. I invite all the dignitaries to light the ceremonial lamp.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तु ते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं ते मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठे गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशः
Thank you, sirs and ma'am. As a beacon of wisdom and leadership for our institution, I humbly request our chairman, sir, Dr. M.R. Hulinaikar, sir, to kindly address the gathering. The stage is yours, sir.
Good morning to everybody. Respected dignitaries on the dais, respected teachers, delegates, and students. Indeed, I'm very happy to be here. Today, we are doing CME on allergy with the efforts of Department of ENT and Pulmonology. Really, it is a very interesting and very useful subject to discuss, because day in and out people are suffering with allergies because of the changes in the environment, the food habit, the food preparation using different colors and many things they are mixing with the food. So also the cosmetics, many things. Because the comforts of the human being, people are using different kinds of things in day-to-day life. Because of these things, people are oversensitive to these subjects, suffering with the allergies, starting from the simple rhinitis to the asthma, etc. So also people suffers with the skin ailments also. Now people are started identifying which is the culprit of the allergies, how to manage, how to sensitize these people. So many things are happening. Many understanding has come. It is high time to discuss these things with the experts in the field. I really appreciate the Department of the ENT and the Pulmonology people who have initiated and called many experts in the field. I wish this will be a wonderful, informative session, so that especially youngsters and postgraduate students will get more benefit out of this CME. We all enjoy this informative and academic session of Allergy Unveiled. I wish all the success. Thank you and all.
Thank you, sir, for your valuable address. I would take this opportunity to request our dignitaries to felicitate our distinguished speakers as a token of our appreciation for sharing their knowledge and time with us today. Dr. Soumya MS Ma'am, Senior Consultant ENT Surgeon at Narayana Health, Electronic City, ex-Professor at St. John's Medical College, Bangalore. Dr. Puneet K. Nagendra Sir, Professor, Dayanand Sagar Universities, Bangalore. Give one here. Vote of thanks on this. Vote of thanks on this. ikkada. As we near the conclusion of today's event, it is time to acknowledge all who contributed to its success. I request Dr. Malvika Venugopal from the Department of Pulmonology to present the vote of thanks.
Good morning, respected dignitaries, esteemed colleagues, and dear delegates. On behalf of the Department of ENT and Department of Respiratory Medicine, it is my proud privilege to propose a vote of thanks for today's CME. First and foremost, I extend our heartfelt gratitude to our respected chairman, Dr. Hulinaikar sir, whose constant vision and encouragement continues to inspire us. We are deeply thankful. We are deeply thankful to our director and trustee, Dr. Raman sir, and Dr. Lavanya madam in her absentia, our pillars of support, whose dedication and encouragement have been instrumental in making this program a reality. A sincere thanks also goes to MS Patil sir, Director HR and IT, for his valuable support and goodwill. We are especially grateful to our MS sir, Dr. Mohan Kumar sir, our principal sir, Dr. Harindra Kumar sir in his absence, and Vice Principal Dr. Rekha madam, Dr. Hemant sir, whose leadership have been central in making this academic gathering possible. Our special thanks to today's speakers, to Dr. Soumya madam and Dr. Puneet Nagendra sir, for graciously agreeing to be a part of the CME and for accepting our invitation to share your knowledge. Special thanks for delivering such insightful and thought-provoking lectures and for providing newer insights in the topic of allergy, ma'am. And a special acknowledgement goes to our chairpersons, Dr. K.L. Shivakumar sir, Dr. Narayan Swami sir, Dr. Virupaksha sir, Dr. Munishwar sir, and Dr. Maunish sir. I would also like to acknowledge the wholehearted participation of all the delegates, postgraduates, interns, non-teaching faculty members, administrative and non-administrative staff, IT team, especially Varun for tech support in graphic designing, Ms. Bhagya from Central Stores, and Mr. Venu from the office, without whose involvement the event would not have been so vibrant and successful. With this, I once again thank each and every one of you for your valuable presence and contribution to making the CME a success. Thank you.
ಶಿಷ್ಯನೇನು ಎಲ್ಲ ಹೊಂಟೋದ್ರೆ ಕಷ್ಟ ಅಲ್ಲ ಅವ್ರು ಹೋಗ್ಬಿಟ್ರು ಕಷ್ಟ ಟೀ ಬ್ರೇಕ್ ಅಂದ್ಬಿಟ್ಟು ಹೊರಗಡೆ ಹೋಗ್ಬೇಕಾದ್ರೆ ಎಲ್ಲ ನಾನು ಹೇಳೋದು ಸ್ಟೂಡೆಂಟ್ಸ್ ಬೇಕಾದ್ರೆ ಟೀ ಬ್ರೇಕ್ ಅಂದ್ಬಿಟ್ಟು ಎಲ್ಲ
Now it's time to recharge with a cup of tea. We'll take a short break. Please assemble back in time so we can continue with our exciting lineup of sessions. We'll have a tea break for 10 minutes. Huh? We will be beginning the next session in the next 5 minutes. Welcome back, everyone. Now we move to an important part of allergy care, that is immunotherapy. Immunotherapy offers a lasting solution beyond temporary relief. Let us invite Dr. Puneet K. Nagendra sir again to take us beyond temporary relief. This session will be chaired by The session on immunotherapy will be chaired by Dr. Virupaksha sir from the Department of General Medicine. Dr. Virupaksha sir, Professor in HOD, Department of General Medicine, will be chairing the session.
Looks like Virupaksha sir has many fans in this hall. Shall I start? Yeah. So we just covered a couple of basic ideas about allergy. So we just sought some knowledge from Madam. Madam, she just spoke about allergens which are there in our environment causing the allergic reaction. We have also seen how to diagnose that allergen and how to see that what is the quality of air that we are breathing. We just saw that whatever we are ingesting, okay, so one is inhalation, one is ingestion. So what is causing food allergy? So these are the most common forms of allergic entry into the body. Now we'll see how this particular allergy disorder in any form, it may involve any organ for that matter. The most common being of course nose, because that is what is the entry of aeroallergens. Then we have the air, as we just spoke about, one airway, one disease. So if the nose fails, then the lungs gets involved. So in the form of asthma, then of course in the form of skin reactions, and then the gut reactions. I'll just walk you through a few of the basic concepts now. Then there's something called as hypersensitivity reactions. That is what we saw in the beginning. So what is more important for us is type 1 and type 4 allergic reactions. Type 1 is Ig mediated, type 4 is T cell mediated, which is usually seen in skin allergic reactions, especially the contact dermatitis. Then we come to the concept of allergic march. So it's very important for us to understand what is this march. Most of the times, as I said, there's a family history of allergy. Either of the parents would have allergy or the grandparents would have allergy. So there's an exposure to the fetus during pregnancy, and then the allergy continues until maybe a few years in the early childhood, or it may even go beyond the adulthood and senior age. So the family history is very important, and the initial manifestations of allergy usually in the form of skin rashes or in the form of eczema or atopic dermatitis is very common in children. So pediatricians and dermatologists would verily agree with this. And also, if few of your medical students who have been very keen in clinical examination, you just observe any pediatric patient, especially with the respiratory symptoms, would have had some of the skin manifestations. Then we come across most common being food allergy, then comes to rhinitis, asthma, and then if the asthma persists, then it becomes COPD. This is the march. So this sequence of involvement of the organs is very common in most of the population. Then we see this specific thing, as I said. So it's very important that asthma, which starts in early childhood, may just by the adolescent age, it just wanes off. Whereas the allergic rhinitis persists for a long time. It doesn't go away without treatment. Whereas the eczema also comes down as we see in asthma. It peaks early in the age, infancy. Then the food allergy. Food allergy generally is better when you are adult. Then the allergic triad is very important. These are very common clinically, so that we just go into the immunotherapy later to see who gets better with immunotherapy. That's why I'm giving these concepts. So the allergy triangle, usually any case of allergic rhinitis you see, in your maybe in your relatives, maybe in your friends, or maybe the patients you visit, they would have some component of asthma, some component of skin manifestations. It's very important not to ignore those. So most of the times we are just becoming organ specific treatment. Let us also now venture into the other organs. Let us keep our mind open, eyes open, and let the patient get a complete relief rather than the organ specific relief. So generally a patient might have asthma, may have eczema. So we just come into this concept of what are the kinds of allergens. We just recapitulated because it's important to understand how to give immunotherapy. We have the contactants, we have the ingestants, we have the inhalants and the injectants. Okay, these are the 4 forms of allergy entry into the body. It's very important. The contacts, the current generation are very fancy about using different colors, I mean the different covers for the mobile. Okay, so most of you might be having some kind of allergy in your fingers, but trying to ignore that it is something else. But most of the times it will be your silicone covers or your metal covers which are most commonly causing contact dermatitis. Then we have food allergy, we just covered it. Injectants are most common injectants day in and day out we see is drug allergy. Okay, very common. Please pay attention to the drug allergies. They would have some amount of allergies in any of these forms. Okay, then the inhalants are there, but I would say it's not as common as we see in Europe or Australia. So it's very important to understand what kind of testing is required before you start an immunotherapy. Okay, so all the patients should have undergone these 2 important tests. Skin test is a must, no doubt. Blood test is an added advantage to confirm the diagnosis of allergy. What kind of blood test? So specific IG and basophil activation test is what we talked about, but the specific IG is sufficient enough for us to confirm the diagnosis of allergy. There's another important aspect of treating a patient with immunotherapy, that is the lung function test. It's important that we saw earlier, allergic rhinitis is the most common form of allergic manifestation, but at least 50 to 60% of allergic rhinitis patients have found to have asthma. So it's important that before you start treatment for allergic rhinitis, it is important to evaluate for the status of asthma, because most of the allergens you give as immunotherapy may trigger an asthma attack. So it is a rule that above FE1 above 70% is very important to achieve before you start a patient with allergen immunotherapy. So laboratory test, I said specific IgE. There are other laboratory tests which are being commonly used, that is the total IgE, eosinophil count, but these things don't have any value in initiating or monitoring immunotherapy. Other 2 tests which are commercially available, immunocap and radio immunosorbent assay. Now this RAST is kind of obsolete now because of the radiation involved in the procedure. Okay, so we don't have RAST anymore, but we have immunocap and ELISA. ELISA is quite common. Immunocap is more specific, but it is quite expensive. So these tests are very important, easily performed in children. So children, just a few ml of blood, we require at least 4 ml of serum from any patient to diagnose or to perform the panel of allergens. So this 4 ml is easy to get from any human body. So that's why they're easier to perform, but they're expensive. But it will only detect the circulating IgE. Okay, it doesn't detect anything else. So in our center we have a specific IG panel. For your understanding, I'm just giving you how this panel looks. Okay, this is the allergens groups. Okay, so we have the aeroallergens. Here you can see we have graded it as you can see green, yellow and red. Red is something very high in kilo units. Okay, So international units is what is the antibody is evaluated with. So we assess for how much of these allergen antibodies are there in this particular blood. So for this patient, um, the holoptilia is a flowering tree. It has very high level in this particular patient. It has means it has more than 5.5 um, SAU per ml of antibodies. So this is the how you interpret this particular reading. This is again food allergen. So here you can see mango and cucumber which are low, which are generally not considered as significant. So low is not considered significant in specific IG. This is the detailed part of the report, which is most of the grass pollens, pollens, and then the tree pollens are there. So here you can see each of these parameters, they have been given the SAU units per ml. So bajra, okay. So bajra is commonly used food. I mean food as well as available in the ground. So it is class 6, which is severe. Typha angustata, which is a pollen, which is showing only 3, which is moderate, and the another tree pollen, which is holoptilia, as I said, which is high. Okay, so this is how the local name. Okay, so any other local name I would bring in silk grass. Then we have sunflower, very common. Then congress, that is parthenium. So these are the allergens. Like that, we do for about 200 allergens. So then these are the specific IG tests. Now the skin test, the skin prick test, which madam will demonstrate in the next session. It's very interesting because very immediate you get a reaction, and very satisfying also because you have a confirmation. The patient also has a confirmation. He sees the response and as well as feels the response. You'll see what is that feeling the response. So SPT generally done after 20 minutes. Since madam is doing, I'll just skip this. So these are the allergens which we use commonly. This is the kit which we use, and this is the kind of reaction. This is one of the patients with Dr. Munishwar's clinic. So sir was very surprised to see such a reaction. We could actually not demarcate between the reactions. So he sent me the pic. I thought I'll just put it. So I've also not seen so much reaction for any allergen, but however this group belongs to dust mites. So this is the kind of reaction you can see in the skin. Probably if someone is having allergy, as madam said, get it tested. We are here. Madam is doing it free of cost, which would cost at least few thousands, which you will save. Okay, so we'll come into the treatment with this background. So we understood what is the spectrum of diseases, what are the diagnostic tests, and what should be considered for immunotherapy. As earlier also it has been said, avoidance is very important. It has to be part of the treatment. There's no doubt about it. Education is much more important because you have to tell the patient what it is. It's a fever, you write an antibiotic, that's okay. It's only 5 days. But then immunotherapy, which goes for months and years. So it's important that you educate the patient. Without proper education, it's unlikely to be successful treatment. Okay. So we have the parameters that we have to look into the education is hygiene. Hypothesis is something which has been taught to you guys in pediatrics. I'm sure you know about it. Breastfeeding is very important, and smoking. Smoking, people think it's a fancy thing. It would have started with peer pressure. Most of you who smoke, you know why you started. So smoking beyond certain age is probably should be stopped, being medical fraternity. Then allergen avoidance. Pharmacotherapy, we know this group of drugs. It's very important to know we use them day in and day out, but we don't know what kind of effects they have on a long run. So it's important to know the long-term effects of these drugs before we start prescribing them to the allergy patients. Now we'll go into the immunotherapy. So the definition says allergen immunotherapy is an allergen vaccine to an allergic subject reaching a dose which is effective in ameliorating the symptoms associated with subsequent exposure to the causative allergen. Okay. So it involves repeated administration of an allergen to induce a state of immune tolerance. So immune tolerance is what we are talking about today. So it's not that you should not educate the patient in immunity chanagilla, we are going to improve your immunity. The patient is not having HIV because the immunity is low. The patient is having hypersensitivity response. It doesn't mean his immunity is low, but the immunity is gone beyond the control. So it is showing hyper responsiveness to a common allergen which is not allergic to a common person or a normal person. Okay. So the forms of immunotherapy are oral, bronchial, nasal, and sublingual. So it's important for you also to understand or get aware. So we have these forms of immunotherapy. Okay. Sorry. So what we commonly use is sublingual or subcutaneous. Then the oral immunotherapy is available for certain food allergens. And we have bronchial, which is again for research, and nasal also is research. What we use is both. Okay, subcutaneous is what I have not included. So I'll talk about subcutaneous immunotherapy. It is quite old. It is not started recently. It has been started at least 100 years ago when people started treating it for immunotherapy. In Europe, it's a very old practice of immunotherapy. Only in India, because very few people are trained in immunotherapy, it is not being practiced worldwide. I mean, throughout the country. It is there, but only in prominent institutes only. So we'll see how this immunotherapy will give the effects. Okay. So this particular diagram is very important to understand immunotherapy. Only when you understand its effects, only then you also will be convinced that you should suggest this for a patient. So please pay attention to this particular diagram. We know that it's a dendritic cell. So it is the first responder to any foreign protein. The moment it is triggered, it is communicating to the T regulatory cell. Now the T regulatory cell will, I mean, this was covered in the first session, but just for brush up, the T regulatory cell will have an effect on the Th2 cell and Th1 cell. So these are the two important cells which are communicating the allergy inflammatory response. So the Th2 cell will release interleukin 4 and 13. I'm just giving more and more what is important. Just pay attention to that and remember it, because these are something important in most of the inflammatory pathways. The Th2 cell further has an impact on the mucosal cells. Okay, and also it has the effect on the B cell. Okay. Now the T helper cell, the T regulatory cell can directly affect the activate the mast cell, the basophils, and the eosinophils. Okay. So now the immunotherapy in the form of subcutaneous or the sublingual form can produce these many actions. What it will do further, it will activate the T regulatory cell, but then the T regulatory cell down regulates the activation of the Th2 response, which will prevent the activation of the inflammation in the mucosa and also inflammation of the, activation of the dendritic cells, so that there is no further movement of the, activation of the dendritic cell. So here you can see it will suppress the mast cell degranulation. It will prevent the eosinophilic cell activation, and it will prevent, and it will, we'll see in the next slide what the changes are. So this is the inflammatory pathway. Okay. So this is what immunotherapy does. You can see there's so many interactions, but then the T helper cell response has switched over from Th2 to Th1. So this is what immunotherapy does. So it is switching the inflammatory response from T helper cell 2 to T helper cell 1, which is a healthy inflammatory response, which will release TGF beta, which will regulate the B cell, and it will further release the IgG4 and IgA antibodies, which prevents the mast cell degranulation. So this is a very important step. This is where immunotherapy is going to change the allergic inflammatory pathway and give a better response than your antihistamines. What antihistamines do? They act on the chemicals released by the mast cell. This is where your antihistamine action. What biologicals do? They act on these interleukins. Okay, they act on one of the pathways, but whereas immunotherapy is acting at the level of the shifting the inflammation from Th2 to Th1. So I hope these three differences are clear to the audience. So that is what the immunotherapy duration takes 3 to 5 years. It can't happen in few months because we don't have ways to assess what is the magnitude of IgE being activating the mast cells, what is the amount of chemicals released by the mast cells in the body. We don't know the immune status by which the person will take so many days to switch over from Th2 to Th1. That is where the immunotherapy duration is variable. So there is an n number of evidence. I thought I'll bring up only the latest, something beyond 2010 in the last 10 years. Okay, so that is where I brought only this slide. But then lot of studies have been done earlier as well. So these are the studies which have been done for asthma. Okay, so what we can see is they have done SCIT versus placebo, and they have considered house dust mite. So the efficacy is good, whereas in case of SLIT, which was done again for the house dust mite and the grass and the birch pollens, the efficacy is also good. So what green means, it's good. So when we see allergic rhinitis and rhinoconjunctivitis, please pay attention. This is asthma and rhinitis. So you can see there are much more studies related to allergic rhinitis, and the response is much better in allergic rhinitis. So you can see there are much better response when there is studies have been done for the pollens, because in Europe and Australia, the pollen allergy is quite common. So they have picked up and done more studies for pollens. But later on, as you can see, the studies which have come later, like maybe 2016, 15 and all, you can later see there are more of house dust mite. This is one meta-analysis which finally says that SLIT, so many studies have been done, then they're all randomized controlled trials, and for different conditions and different pollens and indoor allergens. And at the end of the analysis, you see the studies have been making a difference. There is a good response to the immunotherapy. Now, why allergen immunotherapy? What are the outcomes? So the clinical outcomes, we saw something at the molecular level. Let us see the clinical outcomes. They have done studies, clinical studies, which says there is a good symptom control in case of asthma and as well as allergic rhinitis. The requirement for rescue medication in the form of nebulization, visits to ER, use of most commonly called Asthalin inhaler for asthmatics. The quality of life is better. The people or the students who are going to the school, they are now going to the school regularly. The people who are being absent for their work, they are going regularly. That is what is quality of life. They are having better sleep. Then we have skin responses. Most of the skin manifestations are just vanishing with treatment. And the occurrence of new sensitization. Someone who is having allergic rhinitis would develop asthma or skin disorder in the later part of life. Now, this particular person is not having any new sensitization in any other organ. So they may develop something in the eye, allergic conjunctivitis. They may develop something in the hair also. There is hair fall. Hair fall is becoming less. So hair fall is most common manifestation of allergy. What we saw, the cellular outcomes, as I said earlier, so it is the interleukin 5, interleukin 10, which are more there, and TGF beta and interferon gamma. So the eosinophils are less in number now with the cellular outcome. The basophils also become less in number. The mast cells become less in number. So this is one guideline which is related to asthma. So what we see here is the step approach towards the treatment of asthma. So it is, we usually start with something called as SABA, which is short acting beta agonist, which is as and when required kind of thing. Then we go to step 2, which is low dose inhaled corticosteroid. Then we go to step 3, which is maintenance, low dose. Again, it is a combination of ICS and long acting beta agonist, which is usually commonly used as budesonide. Then we use fluticasone, then formoterol, salmeterol kind of combinations. Then we have high dose maintenance, which is high dose. The 200 becomes 400, so that is what would become high dose. 2 times 1 puff will become 2 times 2 puffs kind of thing. Then we have something called as biologics. So that is what is step 5. When this is the guideline for the asthma management, we could see here there is something at the bottom in the gray. They start house dust mite slit, that is sublingual immunotherapy. This is what is guideline given by GINA, which is a global initiative for asthma. They say any adults, adolescents, and 12 plus years of age can be suggested immunotherapy if they are sensitive or if they are found to have allergy to dust mite. So currently the evidence for dust mite has given a better response. So only the guideline has included dust mite. So dust mite is something which we see in our carpets of these seats and anything in the air condition, what do you call the filters, and then the curtains, so the thick curtains and the bedspreads. So we commonly see this house dust mite. So this dust mite is a very small creature, and then it crawls, and then it feeds on its own dander, and it also feeds on the fiber. Okay, so so many a times we would have heard most of our grandparents or parents telling us not to eat on the bed or sofa. We are always asked to eat on the dining table. So these might be a few of the reasons which they have an insight. Many of the food particles, even a small 1 grain of rice falling on the bed can be a food source for the mite. Okay, so this is what I wanted to highlight. The HDM slit has been started in the initial stage itself when the person is diagnosed to have allergic rhinitis and bronchitis or asthma. This slide already Soumya madam had covered. This is a guideline for allergic rhinitis. Here also they consider immunotherapy, specific immunotherapy, even for the intermittent or the persistent allergic rhinitis symptom. They have a better response. Now the immunotherapy is a kind of precision medicine. Why it's called precision medicine? It's very important. No more the drugs or the especially we are well versed with the management of diabetes and hypertension. I'm sure sir will also agree that not all patients receive the same combination of antihypertensive and diabetic medications. Not all diabetic patients will be on insulin. So similar, that is a kind of precision. There is more precisionness will come into that particular disease when more studies have been done, when more phenotyping will be done. So similarly, in this particular patient with asthma or allergic rhinitis, we have to phenotype them. So we have to phenotype by checking their, going in, digging into their history, and also looking at the allergen profile, which we have done earlier. So that is specific IgE, and also looking at their skin prick test results. So these are very important, and then only you suggest some immunotherapy. It's not that any patient who comes, I have a immunotherapy combination because I have large production of the drug, so I give the same thing to the patient. It's not like that. So this particular step has to be followed in immunotherapy, and then only the patient has to be suggested what is the combination of the allergen, how much should be combined is what is important in immunotherapy. So it's important to identify the patient at risk, to understand if they are in that allergy march, are they having many exacerbations, is the exacerbation is under control before you started the treatment. And then it is important to understand whether the person is suffering from an acute illness or chronic illness. Many a times when a patient comes with acute symptoms, just a 1 week of allergic rhinitis or 1 week of bronchitis, and you say, oh, I will do a test because now I have attended some CME, and you will go this battery of tests, and then I will do a skin prick test, you come after a week, then we'll start immunotherapy. Do you think a patient will agree? They will never agree. So it's very important to understand what is that patient, does the patient, is it a right candidate for immunotherapy? Is the patient a right candidate for pharmacotherapy, is what has to be ascertained by you, and then only you suggest immunotherapy. So sublingual immunotherapy, the just for a understanding, usually given in the arm, so subcutaneously, and the sublingual is some in the form of tablet or drops, is kept under the tongue. Now, how long this drug has to be kept under the tongue? So the idea is the person who is having this allergic disease will be diagnosed by the blood test and the skin test, and we know the allergen. Now we combine 2-3 allergens, and the allergen in the pure form is extracted in that particular drop or the tablet, and then asked to keep under the tongue. Now this immune response is mounted. So it has to be exposed to the dendritic cell in the oral cavity, on the oral mucosa. So it's important that the exposure should be longer. So idea is that the person should venture out holding the drug in the mouth for a longer time. So why that is why again it is subcutaneous and it is not intravenous. Intravenous would lead to a response. It may lead to an anaphylactic response because the allergen is injected into the system, and there is a sudden rush of so many allergens that the body thinks there is some allergen entering, the foreign body is entering, so it will mount an immune response in the form of anaphylaxis. So it is subcutaneous and sublingual. Now this I just covered this. So what is the safety of sublingual immunotherapy? Okay, before that, let me go into something more about dosing. When it is subcutaneous immunotherapy, it is having a weekly schedule and a fortnightly schedule and a monthly schedule based on the as and when immunotherapy proceeds. But when it comes to sublingual immunotherapy, it is a daily dose, and a higher dose of allergen has to be there in the immunotherapy. That is because we know that the oral cavity has many secretions, and then it has many, the secretions contain many enzymes, and these enzymes are against the protein. So it is bound to get denatured. Okay, so the dose of response, it is almost I would put it as 1,000 times the dose of the subcutaneous immunotherapy. This is how a prescription for immunotherapy would look like. So you have to make sure this is a proper patient identification is very important. There should be since it's a personalized, you need to have a number to that particular patient. The name, age, the phone, and the email ID, all this information is important. And just for the information, we can combine up to 4 or 5 allergens. So it's important that you mention what are the allergens in that particular immunotherapy are covering, what were the SPT results of that particular allergen, and what is the percentage of allergen in that particular combination of immunotherapy you have going to provide to the patient. So what is the units of allergen? So we usually call as biological units, because as we have in case of ciprofloxacin, we have 500 milligrams. Similarly, allergen for a house dust mite, we call it as 2800 biological units. So that is what we commonly use. Then the dose is it 1 tablet, 2 tablet, and the dosage is it once daily, twice daily, and the duration. So is it 2 years, 3 years, or 5 years is what you have to decide. So this is how precise it should be immunotherapy schedule. So we have couple of studies which looked at the safety of this immunotherapy. So the most of the things when you see, these are the local reactions and the systemic reactions. The local reactions are, there is edema of the oral mucosa, then you have the pruritus, then you have throat irritation, then some non-specified tingling, certain things also they come up there, but they're very less common. Okay. Then we have some systemic reactions, that is nothing but aggravation of the existing allergy symptoms. If the patient is having eczema or the patient is having urticaria, that would increase quite a bit. And then the same thing, conjunctivitis, rhinitis, asthma, cough, and all those things. When we see, there are so many studies which has been done, and then you can see what is that with the placebo and the total events you see. And when what in whatever studies has been done, you can see the maximum is 3%, I mean, and the least is 0.1%, and 0 as well. Anaphylaxis is 0 in sublingual immunotherapy. Whereas in subcutaneous immunotherapy, there are chances that the patient may get anaphylaxis, whereas they don't have other battery of symptoms. Local reactions are all quite less. So how do we choose whether it's an sublingual or a subcutaneous? It's always, when we have choice in therapy, it is always risk versus benefit. So this concept is important in any treatment. When we take efficacy, it is definitely SCIT. So SLIT is also efficacious, but then it takes more time and it takes daily dosage. Whereas the safety, SCIT has the reaction, as I said, anaphylactic reaction is quite common, whereas I have not seen any anaphylactic reaction so far in SLIT. So this is one small study so that you just know what is happening when we do therapy. So this is a case of allergic rhinitis, also having asthma, but I have just brought in the element of allergic rhinitis. I just studied 165 patients who were on immunotherapy on a follow-up of 5 years. Okay, and there were 43 patients who are continuing treatment. You can see this is the kind of commitment the patients have. What is that most common therapy we come across in our routine thing is TB, which will be around 6 months. 6 months TB treatment itself is a very challenging thing for us, is it not? So this patient has to undergo therapy for at least 3 years to see some response, to mount some response and to maintain. So compliance is the major issue for any patient on immunotherapy. Okay. So what we saw in these patients, the symptom score reduced from 14 to 4, and then we saw the medication requirement, it reduced from 2 to 0.8. Then the combined symptom and medication score from 16 went on to 5. Here you can see there is no, it's not going to 0. So that is also very important. None of the parameters are going to 0, because the severity of patients which we get are different. So the most chronic and the most severe patients may feel better, at least the symptoms are getting under control, because there are patients with allergic rhinitis and asthma, they don't get better with any amount of inhalers, any amount of oral corticosteroids or intravenous steroids. They only they, at least if they have allergic symptoms, they do better with immunotherapy. So these are some things which are commercially available. So of course, I didn't add this SIMS&RH, which was one of the products by Reddy's Laboratory, and the company is, you know the company SIMS&RH. Yeah, Alcabello, is it? Reddy's only. Okay, so it's manufactured by them. Okay. So the Reddy's have that is what was introduced recently in the less than 6 months. It is available. So the cost of therapy, for your understanding, it should be around, for 10 days it's around 2000 plus. Okay, so this is what immunotherapy costs is. Whereas the same immunotherapy, I would like to bring to your attention. It is the tablets cost is 180 to 200 euros per month. So in case of what is available in the European market. So we can't close any chronic disease without talking about immunological, biologicals. So these are the list of biologicals which are available for the treatment of immunotherapy, uh, allergy. So I just want to bring your attention um, to this because this is how it is different from immunotherapy. Here you can see at each chemical mediator of the reaction, we have a list of monoclonal antibodies. So at the level of interleukin 4, where it is, the T regulatory cell is now transforming to T helper cell 2, we have interleukin 4. These are the things which are available. Dupilumab is what is quite available and effective. Whereas in case of T helper cell to neutrophil activation, we have infliximab which is available. Then at the level of interleukin 13, I think lebrikizumab is available, and Ig antibodies against this, omalizumab is available. This is very available. Just last week also I gave to one patient having eczema. So the cost is 36,000 rupees for one vial of injection. So that is the cost of biologic therapy. But then the patient was better. Today I injected, and after 3 days the patient didn't have any symptoms. So then we have these three drugs: mepolizumab, reslizumab, and benralizumab, which is against interleukin 5. This is very commonly used for asthma in especially America. It's also being used in Bangalore as well. So this is about monoclonal antibodies. So let us pay attention to the allergy triangle, which is asthma, allergic rhinitis, and eczema. It's important to know what is the allergy march, where is the patient marching towards, and what are the exacerbation risk and exacerbation events in this particular disease journey, and whether the disease is chronic or acute. Immunotherapy is approved by FDA, and it has many evidence that it works for patients with chronic allergies. And the basis of immunotherapy is precision medicine. It has a long-term effect than what we generally use in the form of pharmacotherapy. So it's a team effort. So I would say ENT surgeon, a pulmonologist, a pediatrician, in fact, a geriatrician and a gastroenterologist and a dermatologist would all team up together and really work for the betterment of allergy patient. So now in our hospital, most of the allergic rhinitis patients are sent to pulmonology, not only for an opinion, but also for a pulmonary function test. The same way, any patients with asthma, I do nasal smear. That's because ENT surgeons are more busy doing surgery, so they are not available for taking up nasal smears. So I take up the nasal smear. If I find it something, I refer them for treatment. So this is what currently we are doing. And most of the pediatric patients with asthma, they're sending to pulmonologist. Earlier, most of the pediatricians were used to treat asthma because they can treat. It's not that they can't treat, but still they want the pulmonologist to have an opinion to look at what should be the spectrum of medications the patients would require. So this is what I'm seeing. There is now team up, and now we can see the CME is organized jointly by ENT. Of course, the initiative is by ENT, and the pulmonologists have joined in. Thanks for the ENT people to take up such an initiative. And also the pulmonologists have actively accepted that immunotherapy can be done, because we see immunotherapy is most effective for rhinitis rather than asthma. So none of the pulmonologists are very keen to do immunotherapy, including our friends here. They would not even do a skin test. I'm sure probably they'll learn it today. Manju, so probably you can start referring patients to ENT. ENT people are doing skin tests. Okay, nice. So with this, I would end this talk. Hopefully, I've given a broad overview of what is immunotherapy. Let's work towards giving patient a better quality of life and better management of allergic diseases. Thank you.
Thank you, sir. It was excellent presentation. You explained in detail regarding immunotherapy from basics to till the biologicals. So my question is, if you do skin prick test, if you won't find any allergen, is there any role of immunotherapy in that situation?
Sir, actually, skin prick test is what is available. I didn't go to the next complicated stage of management where we have challenge test. So, if the patient is having allergic rhinitis, we do nasal challenge test. If the patient is having asthma, we do broncho provocation test. You would have heard of these things, but then again, these things will turn up because most of the times, what we do in skin test, no, we are detecting the mast cells which are there in the subcutaneous tissue which are activated. Many a times they may not be present in the skin. So they may be localized only in the area or the organ involved. So it is very important such patients, if they're clinically diagnosed as allergy, has to be subjected for provocation
So you
test.
can do immunotherapy in that situation.
Yes, sir. Yes, we have to do.
What is the success rate?
Sir, success is 70 to 80%. They're better, sir. They're doing really better. As I said last week, I treated one patient with omalizumab. That patient took 3 years of immunotherapy. She stopped for about 3 months. There was a recurrence of symptoms. But then when she was taking she was off antihistamine, she was off all those creams for urticaria and other things. So this kind of response is also there, where we have patients, they're doing better when they're on immunotherapy. When they're off immunotherapy, they have the recurrence of symptoms.
So there is a relapse.
Relapse is there. So I would say such patients, there are also patients who are taking immunotherapy for almost 10 years, 12 years. They're happy. So they are off the pharmacotherapy. That is what they're happy, because their
So compliance is important.
compliance is important.
Thank you, sir.
Thank
Any
you.
questions from
One
audience?
question. Punit, when do you say immunotherapy is not working? Like you start the immunotherapy and you consult patient for 3 years, 5 years. And what stage you see that you say that it is working or not working?
So in practice, there is no guideline for that as such, because studies have not been done, and probably if studies have been done, that's where they're suggesting not less than 3 years they're seeing any response. But since our patients are not having much of patience, nor they have because it is very economically, financially burdening. So we generally ask them to at least take for 1 year. 1 year would definitely show some response, if not a good response. So that itself will give us an indication that okay, this immunotherapy is working for this patient. Less than that, it's very difficult to comment, because in my practice also, I've not seen less than a year. Of course, we have seen patients at least 2 months and 3 months of immunotherapy, they are doing much, much better. But then if we stop, there is recurrence of symptoms.
So minimum 1 year you say that 1 year of therapy.
And there are many patients who have taken for 1 year, they have stopped, they're still doing better. 5 years, 6 years, they're doing better. But we have also seen such patients coming up after 8 years, 10 years with much, much worse symptoms than what they had presented earlier.
Okay, and you see a patient and you think it is immunotherapy is failed. And what do you do next?
Sir, there is no, I have not seen failure to immunotherapy.
Okay.
That is there. But then if they are affordable, they can take biologicals.
Okay. And
Or if they are not affordable, of course, our pharmacotherapy works well, but with the cost and the adverse reactions which we have to bear.
okay, is there any method to cut short the duration of therapy? Like instead of 3 years, 5 years, can you cut down to?
So 5 years was what was said earlier. Now it
Yeah.
has been cut down to 3 years.
Okay.
I think they're doing some studies where they're seeing that if there is a better immune response in the early phase, where they can certain routes like intralymphatic. So they are seeing that response is better. If such kind of routes are established and forms of therapy is available, I'm sure that will reduce the duration as well as the doses for immunotherapy.
Okay. And any criteria to prescribe omalizumab? Any guidelines?
Yeah, so omalizumab has a time-tested biologics. So it has been said that it's usually coming as 150 milligram and 300 milligram. So any patient with chronic allergy symptoms and proven that this patient is allergy, all these regular tests, and then we confirm this is an allergy, we can give straight away. We can give, and every 2 weeks we have to administer. Now we can start with 150 if that works. That's fine because it's expensive. Otherwise, they usually decide 150 or 300 based on the total IgE levels. So that is the guideline available.
So we have to do total IgE levels first,
Total IgE.
and specific IgE for immunotherapy. Then.
Immunotherapy specific
IgE. And omalizumab we have to do
we
total
have to do
IgE
total
levels.
IgE. And then you can also monitor omalizumab through total IgE levels.
Okay.
So that will at least give us some response. I mean, some idea how we can guide this patient for long-term biologic therapy.
Okay. Any contraindications for omalizumab?
Hypersensitivity to omalizumab or any other drugs earlier. So they say this is what is the contraindication. Otherwise, there are no other contraindications.
Means you give test dose, is it?
We have to give test dose.
Okay. Any contraindication for immunotherapy?
Immunotherapy, definitely. There is no family support. There is no financial backup. Better not to start them on. Give them some beliefs, and it's very important that they need to sustain. Family support is very important. Finance is important. Then the person should be compliant. So the person should be able to understand what we are explaining. These are all absolute contraindications. Of course, relative contraindications. Absolute is any hypersensitive reaction to earlier drugs or immunotherapy. There are patients who have taken treatment elsewhere. They had some allergic reaction. They would come to you. It is important to ask them because they would not like to speak about that event. So it's important to ask whether you have been given immunotherapy elsewhere. What was the response, and is there any reaction? And all these things are very important. Earlier anaphylaxis is very important to note down.
Okay, thank you.
Yes.
So if no more questions, thank you, sir.
Yes,
thank
sir.
you for
Thank you very much.
presentation.
Thank you, sir, for the insightful session on immunotherapy. Your clear explanation and practical tips have made this complex topic easy to understand and apply in our practice. May I take this opportunity to welcome the trustee of our institution, Dr. Lavanya Raman ma'am, to our CME. We welcome you, ma'am. Ma'am has been very encouraging and supportive in organizing this CME. Ma'am, I also request you to felicitate our chairperson, Dr. Virupakshappa, sir. Thank you, ma'am. Let us now move on to the demonstration sessions. We'll be covering skin prick test and FOT. Allergies can be tricky to identify, but the skin prick test makes it visible. Now, we shall see in action how to identify common allergens safely. Our speaker, Dr. Soumya ma'am, will be leading this session. As it was told earlier, ma'am is the first Indian doctor to be awarded clinical fellowship by the European Academy of Allergy and Clinical Immunology. Ma'am also has a fellowship in allergy and rhinology under Professor Peter Hellings in Leuven, Belgium. Ma'am, kindly take over the stage.
Okay. So now for some action. Okay, this is not going to be a lecture series. So I'm not going to bore you once again with topics and talks and slides. So I want some 3 volunteers here in the room. Please come. Please come. Yeah. So you should not have, yeah, we'll do for that also. Patient Kumar. So you should not have taken any antihistamines. Yeah, clap for them. You should not have taken any antihistamines, okay, or any steroids. And she's the patient. Patient, huh? Sit down. Come. So there are certain things which we should know before we do the skin prick testing, okay? So this is basically a simple thing to do, but there is a scientific basis. What are we doing when we are doing a skin prick test? We have a panel of allergens. Okay, there is an allergy kit which is available. So in this allergy kit, there will be some 300 different allergens. Morning, I told you how we are going to choose the allergen. How we will choose the allergen based on the history. Now, there are certain times you should not do the allergy test. Okay, so what are the contraindications to do a skin prick testing? One is in patients who have dermographism. So what is dermographism? There are some people who will have such an acute reaction. Even if you just scratch with your fingernail, the whole skin will become red. Okay, so this is called as dermographism. So patients with dermographism, we will not do skin prick testing. Second, those who are highly immunosuppressed. Okay, so there is no reaction of a wheal and flare. In them also, we will not do the skin prick testing. Okay. So now, how do we identify that the person is a candidate and we can interpret the results properly? We will always test with, for any test, you have a positive control and a negative control. So here, we will test with histamine first. When we test with histamine, all of you should have some itchy sensation. If the person is not having any itchiness when histamine has been tested, then it means that you cannot interpret the skin prick test results. Abandon the test and do it on him. So histamine should be positive. That is the positive control. The second thing is we will do it with saline. Okay. So when we input a drop of saline on your arm and then we lift it up with a lancet, there should be no reaction. Okay. If there is a reaction even to saline, which is the most innocuous thing, it means that patient either has got dermographism. So don't do. Very important, before you start the test, always do the positive control and the negative control. Positive control, histamine. Negative control is saline. Okay. And how many allergens will you be testing? You should be testing 28 allergens like I told you before. Please don't do the bikini method. Okay. Every patch of skin that you find on the body, make the patient strip. Do it on the back, do it on the thighs, on the legs. No. You take a proper history and find out, okay, so what is the probable allergen in that patient. And then we divide the forearm into 14 slots. Okay. So the forearm, you should tell the patient to come with the hands shaved. If they have lot of hair, you tell them you shave the forearm and come. After shaving, then you have to first test for histamine and saline here on the arm. If histamine is positive, saline is negative, then different parts of the arm, you're going to write numbers, okay? 7 on this side, 7 on this side. Use a scale so that there is a space between the two allergens. At least around 1.5 centimeter space should be there, okay? Because sometimes the patient might be allergic to house dust mite. He will also be allergic to pollen. But you have a wheal and flare reaction for the house dust mite and the pollen. There is an overlap. You don't know which one has reacted. Sometimes the wheal and flare response can be very marked, like how Dr. Puneet showed. No, that patient had so many things all together. So we don't know really what is the one which is causing the reaction. So let there be a gap between the two allergens. Fine. So now we will start with our first volunteer. We'll start with volunteer first. Ashwini. With who? With patient you want to start? Okay. Who's the patient? Come. This not taken anything. Yeah, I'll just talk to her 2 minutes. ಏನಮ್ಮ ನಿಮ್ಮ ಹೆಸರು? ಜೋರಾಗಿ ಹೇಳ್ತೀಯಾ? ನಿಶಾ. ಓಕೆ, ಶಿ ಇಸ್ ನಿಶಾ. ಎಷ್ಟು ಏಜು? 18. ಏನು ಮಾಡ್ತಾ ಇದೆಯಾ? Okay, she is Nisha. She is 18 years old and she's studying her second PUC currently. ಏನಾಗಿದೆ ಅಮ್ಮ? ಓಕೆ, ಮೂಕ್ಕಟ್ಟೆ. ಓಕೆ, ಇದು ತುಂಬಾ ಸೀನ್ ಬರುತ್ತಾ? ಹೇಳ್ಬೇಕು, ನೀನು ಹೇಳ್ತೀಯಾ? ಇಲ್ಲ, ಇದು ಓಕೆ, ಸೀನ್ ಬರುತ್ತೆ. ಇದು ನವೆ ಆಗುತ್ತಾ? So she's complaining of difficulty breathing, there is nose block, and she has also got a lot of sneezing and itchiness. Okay, so we'll see. Nisha Balba, Kutkuba. One second. Start ಮಾಡಬೇಡಿ, wait ಮಾಡಿ. Camera. You have. I want to focus this. I will focus. Zoom. Yeah, actually, you come this way. So Nisha has a tattoo on her forearm. If there is a tattoo, try to avoid that area of the skin. Okay. Now here we have this one is the set of allergens. Okay. You can see. Zoom ಆಗ್ತಾ ಇದೆಯಾ? Zoom ಮಾಡಕ್ಕಾಗತ್ತಾ? Okay. Yeah. Now see. You can see there are color. No, it looks like some gems have been kept here. So all these are different allergens. The allergens are all color coded. So each allergen bottle will have around 1 ml and they all have a separate number. So this one, the first one is milk. Okay. It has got a brown color, this one. So it is written milk. And what is the number on this?
1.
Give me that sheet. No?
Sheet.
So we have a list of allergens and the number is given for each thing. See, you can't write milk, then you can't write prawn, shellfish, everything on the patient's hand. So you will write 1, 42, 43, numbers like that. And you place the bottle back into the same place. Okay, you place it in the same place. For example, 1 is milk, 10 is peanut. Then you have 30, which is alternaria, 31, which is aspergillus, okay, 41, which is house dust mite, like this. So we are going to start with Nisha. We'll just tell her, I'm going to explain to her what I will be doing, and then we will start. Nisha, ಇದು ನಿಂಗೆ ಅಲರ್ಜಿ ಇದೆ ಅಂತ, ಇದು ತುಂಬಾ ನೆಗಡಿ ಎಲ್ಲ ಬರುತ್ತೆ, ಮತ್ತೆ ಸೀನ್ ಎಲ್ಲ ಬರುತ್ತಲ್ಲ. ಸೊ ಇವಾಗ ಟೆಸ್ಟ್ ಮಾಡ್ತೀವಿ. ಓಕೆ, ಹೇಗೆ ಟೆಸ್ಟ್ ಮಾಡ್ತೀವಿ ಅಂದ್ರೆ ಫಸ್ಟ್ ಇದನ್ನ ಕ್ಲೀನ್ ಮಾಡ್ತೀವಿ. ಓಕೆ, ಕೈನ ಕ್ಲೀನ್ ಮಾಡಿ ಹೀಗಿಟ್ಕೋಬೇಕು, ಕೈನ ಹೀಗಿಟ್ಕೋ. ಗುಡ್ ಗರ್ಲ್. ಯಾ. ಸೊ ಇಲ್ಲಿ ಸ್ವಲ್ಪ ಮೇಲ್ ಮಾಡೋಕ್ಕಾಗತ್ತಾ? ಇಲ್ಲಿ ಒಂದು ಡ್ರಾಪ್ ಹಾಕ್ತೀವಿ. ಡ್ರಾಪ್ ಹಾಕಿ, ಶೋ ಮಿ ದ ಲ್ಯಾನ್ಸೆಟ್. ಇದು ಚುಚ್ಚಲ್ಲ ಜಾಸ್ತಿ. ಓಕೆ, ಜೆಂಟಲ್ ಆಗಿ ಸುಮ್ಮನೆ ಹಿಂಗೆ ಮಾಡ್ತೀನಿ ಅಷ್ಟೇ, ನೋವಾಗಲ್ಲ. ಓಕೆ, ಸೊ ನಿನಗೆ ಎಲ್ಲಿ ಉರಿ ಬರ್ತಾ ಇದೆ ಅಥವಾ ದಪ್ಪ ಆಗುತ್ತೆ ಅದನ್ನ ಟೆಸ್ಟ್ ಮಾಡಿ ನೋಡೋಣ. ರೈಟ್, ಕ್ಲೀನ್ ಮಾಡಿ. So he is now cleaning the forearm. You can use spirit or you can use sterilium, any solution. ಅದು ಬೇಡ, ಆ ಕಡೆ ಮಾಡೋಣ ಅಷ್ಟೇ, ಒಂದ್ ಕಡೆ ಮಾಡೋಣ ಸಾಕು. Okay, so we'll just wait for a few seconds for it to dry. I'm using a fresh lancet. So abroad, what they do is for every allergen, they will use a separate lancet. Okay. And then they will keep throwing it. Somehow, one is it's going to be expensive for the patient to do that. Second is I'm also worried about the environmental footprints. You're generating so much of waste material. Okay. So what we do, or some people practice, is we will use a cotton. So cotton is, after we prick and take it out, we will wipe it with the cotton. So wipe it properly so that you're not contaminating the allergens. You will put house dust mite, you will not wipe, then you will go and prick on the pollen drop. So, both of them will get mixed up. So we will not get a proper reaction. We don't know if it is pollen or if it's house dust mite. Okay. Saline ಇಲ್ಲಿ? So first I'm going to do with the negative control and the positive control. Okay. So we will make, So we will make a circle like this. Okay. One I will keep for saline and one more for histamine. ಅಲ್ಲ ನೀವು ತರಬೇಕಲ್ವಾ? So just one small drop of saline has been put there. Okay. Next, histamine. One small drop of histamine we will put there. Okay. Sari haki amela the reaction baralla andre. Okay. So we have put one drop of both. Now what I will do? I will take the lancet. Okay. And I'm just going to gently lift up the skin. You should not puncture. No blood should come. Don't go 90 degrees. You should be at a angle of around 30 degrees and just lift up the skin. Yeah. So I'm wiping the lancet. Okay. So now we are going to wait. We will wait for a few minutes and we will see. Relax, Marco. We will wait for a few minutes and we will see if she has a reaction. If she has a reaction to histamine, we will proceed. Okay. ಏನಆಗಲ್ಲ ಇಷ್ಟೇ ಮಾಡೋದು. Okay. ಕರೆಕ್ಟ್ ಆಗಿ ಹಾಕಿದ್ರಾ ಡ್ರಾಪ್?
ಸೊ ಅದು ನಾನು ಆರ್ಡರ್ ಮಾಡಿದ್ರು 20 ಡೇಸ್ ಬರುತ್ತೆ. ಅವರು ಮೊನ್ನೆ ಎಲ್ಲಾರ್ಗೂ ಮಾಡಿಸ್ಕೊಂಡ್ಬಿಟ್ರೆ ರೂಮಲ್ಲಿ.
ಯಾವ ಟೈಮಲ್ಲಿ ನಿಂಗೆ ಇದು ಬರುತ್ತೆ ನಿಶಾ? ಮಲ್ಕೊಳ್ಳೋ ಟೈಮಲ್ಲಿ ಹೌಸ್ ಟೆಸ್ಟ್ ಮೈಟ್ ಇದೆಯಾ?
ಎಲ್ಲ ಇದೆ ಇದರ ಲಿಸ್ಟಲ್ಲಿ 47 ಇದೆ. ಇದು ಎಷ್ಟು ಜನ ಬೇಕಾದ್ರೂ ಮಾಡೋದು. ಇಷ್ಟೊಂದು PG ಹುಡುಗರು ಇದು ಮಾಡೋದು.
ಇದು 1 to 7 ಬರೀರಿ ಸರ್ಕಲ್ಸ್ ಹಾಕಿ.
ಯಾವ್ದಾದ್ರು ಫುಡ್ ಐಟಮ್ಸ್ ಎಲ್ಲ ಸೆಲೆಕ್ಟ್
ಹೌಸ್ ಟೆಸ್ಟ್ ಮೈಟ್ 1 3-4 ಮಾಡೋಣ ಅಲರ್ಜೆನ್ಸ್ 1 3-4 ಬಟ್ ನೀವು ಸರ್ಕಲ್ ಹಾಕೋದು ಹಾಕಿ. ಓಕೆ.
ನಾನು ನಂಬರಿಂಗ್ ಹಾಕ್ಬಿಡ್ತೇನೆ ಮೇಡಮ್, ಗೊತ್ತಾಗುತ್ತೆ.
So what we are doing next, while we are waiting for the reaction, okay, we're just putting circles on the forearm. 7 circles on the lateral side, 7 on the medial side. Okay. So then after putting the circles, so she's telling me that she gets a lot of sneezing when she goes to bed at night. So I'm thinking probably it could be house dust mite. So that is one thing I will be testing. Dogs mura ಅಂದ್ರೇನು? Dogs ಮೂರು ಇದೆಯಾ? ಮೂರು. Okay. So Nisha is very lucky. She has 2 Persian cats and 3 dogs at home. So we will be testing for cat and dog as well. ಏನಾರು ಆಗ್ತಾ ಇದೆಯಾ? ನವೆ ಆಗ್ತಾ ಇದೆಯಾ?
ಬಂತು ಮೇಡಮ್, ಚೆನ್ನಾಗಿ ಇಷ್ಟ.
ಇಲ್ಲಿ ಆಗ್ತಾ ಇದೆಯಾ ನವೆ?
ಒಂಥರ ಇಚ್ಚಿಂಗ್ ತರ ಏನಾದರೂ ಆಗ್ತಿದೆಯಾ?
So we are already seeing the wheel and flare response at the site of histamine. ತಲೆ ಸ್ವಲ್ಪ ಹಿಂದೆ ಮಾಡು, ನಿನ್ ಶಾಡೋ ಬೀಳ್ತಾ ಇದೆ. Okay. So you can see some redness where the histamine is there. ಇಟ್ಕೊಳ್ಳಿ. See, this is saline. Okay, this is saline, this is histamine. You can already see that there is a redness along with a wheal and flare. So we can go ahead with the other tests. Now we are taking the orange bottle cap. One camera to see. That's the orange cap, that is house dust mite. When you're replacing the bottles, no, replace in the same place. Don't mix up everything and then get confused what patient is allergic to. Next. Okay. There are three species which is present in the house dust mite. Okay. You have dermatophagoids, Tyronicinus, dermatophagoids, Farinae, and Blomia tropicalis. Okay. There are three different species in the house dust mite. So we will be testing all of them, and they are like usually the culprits. Most of the times we will get a positivity for that. Same ಅದೇ ಮಾಡ್ತೀವಿ. Okay, wipe ಮಾಡಿದ್ರಾ?
wipe ಮಾಡಿ.
ಅಲ್ಲಿ ಇಟ್ಕೊ, ನೀವು ಇಟ್ಕೋಬೇಕು. So when you come and closer and see, you'll see there is no blood which is coming out. It is just like a gently will lift up. So whatever the mast cells which are there at that particular area of the skin, that will get recruited, and that allergic reaction will be activated because of the IgE. Next kodi. ಯಾವುದು ಕ್ಯಾಟ್ ಡಾಗ್ ಯಾವುದು ಆಂಟ್ ಬೇಡ ಕ್ಯಾಟ್ ಡಾಗ್ ಕೊಡಿ ಸಾಕು. ಇಲ್ಲ ಹಾಕ್ಬಿಡಿ ಕ್ಯಾಟ್ ಅಂಡ್ ಡಾಗ್. So I'm doing for cat and dog. If you are doing this in your clinic, it is very important that you will have a backup tracheostomy set. Okay. You should also have adrenaline, vial, and hydrocortisone, because sometimes patient can have a fatal allergic reaction, anaphylactic reaction can happen. It is very, very rare, but you don't want to lose even one patient in that 1 in million chance. Okay. So always have a resuscitation trolley whenever you want to do a skin prick testing. It's a very rare thing, but we will still do it. So now we're going to wait for around 15 minutes, and we will see if there is any other reaction. Okay, she's also having some itching for the house dust mite. So we will make her sit for around 15-20 minutes. And in 15-20 minutes, we will get to know what she is positive for. Okay. So we'll usually test for more number of allergens. Since it's a demonstration and we have a lot more people waiting, we will just do on everyone a few allergens. And she will be, after that 20 minutes, you can interpret the test. How will you interpret? The reaction, the wheal and flare should be equal to or greater than histamine. Okay. So we have a measuring scale. Each kit will come with a measuring scale. So this measuring scale will be placed on the wheal and flare. Okay. So the measuring scale will be placed here, and we will see how many centimeters. How many centimeters of the wheal and flare response. Okay, we will measure that. So histamine is 5 millimeters.
Saline is 0.
and saline is 0 millimeters. Any of you want, you can come closer and see. You'll be able to appreciate it better. Okay. So 5 millimeters for histamine and 0 is for saline. Now, if anything else comes 5 millimeters as much as histamine, or if it is more than that, it could be 7, 8 millimeters depending on the allergy. Okay. So then it is taken as positive. And when it is considered as positive, if we are having 2 or 3 allergens positivity, patient will be a very good candidate for immunotherapy. If everything comes positive, lots of things wheel and flare, please don't give immunotherapy. It will fail. Okay, so choosing your patient for immunotherapy is very, very important. So the right candidate, if you choose, the results of immunotherapy will be good. Okay. Now Dr. Yasho will do for who's the next person? आपके बारे में आपको थोड़ा बताना है, ठीक है?
ನಿಮ್ಗೆ ಏನು ತೊಂದರೆ ಆಗುತ್ತೆ ಯೂಶಲಿ? ಸೀನ್ ಬರುತ್ತಾ ತುಂಬಾ?
ಸೀನ್ ಬರುತ್ತೆ, ಟಫ್ ಬ್ರೀತಿಂಗ್ ಇದೆ, ತುಂಬ ಟಫ್ ಬ್ರೀತಿಂಗ್ ಇದೆ, ನೈಟ್ ಮಲ್ಗೋಕ್ಕಾಗಲ್ಲ, ಡೇ ಹೊತ್ತು ನೋಸ್ ಬ್ಲಾಕ್ ಆಗುತ್ತೆ, ಈ ಥರ ಪ್ರಾಬ್ಲಮ್ ಇದೆ. ಸೀನ್ ಬರುತ್ತೆ, ನೋವೇನೂ ಇಲ್ಲ.
ಮನೆಯಲ್ಲಿ ನಾಯಿ ಬೆಕ್ಕು ಏನಾದರೂ ಇದೆಯಾ?
ಇಲ್ಲ ಇಲ್ಲ, ಆ ಥರ ಏನು.
ಕಿಟಕಿ ಎಲ್ಲ ಓಪನ್ ಇರುತ್ತಾ? ಮನೆಯಲ್ಲಿ ಬಿಸಿಲು ಬರುತ್ತಾ ಚೆನ್ನಾಗಿ? ಮನೇಲಿ ಗಾರ್ಮೆಂಟ್ ಕೆಲಸ ಏನಾದರೂ ಮಾಡ್ತೀರಾ?
ಟೈಲರ್.
So the patient is a tailor. She could be exposed to a lot of dust mites and cloth dust. ಮತ್ತೆ ಎಷ್ಟು ದಿನದಿಂದ ಈ ತೊಂದರೆ ಇದೆ?
I'm back 10 to 12 years. I'm a surgery patient.
ಈಗ 2-3 ದಿನದಿಂದ ಅಥವಾ ಒಂದು ವಾರದಿಂದ ಏನಾದರೂ ಮಾತ್ರೆ ತಗೊಂಡಿದ್ದೀರಾ ಅಲರ್ಜಿಗೆ? ಅಲರ್ಜಿಗೆ
3 days ಇಂದ ಏನೂ ತಗೊಂಡಿಲ್ಲ.
ಸ್ಟಾರ್ಟ್ ಮಾಡೋಣ ಟೆಸ್ಟು. ಬಟ್ಟೆ ಮೇಲೆ ಮಾಡಿ, ಆರಾಮಾಗಿ ಕೂತ್ಕೊಳ್ಳಿ. She is a tailor by profession.
So do cotton dust.
Yes.
You will have cotton dust also.
ಸೀದಾ ಇಟ್ಕೊಳ್ಳಿ, ಅವರು ಹೆಲ್ಪ್ ಮಾಡ್ತಾರೆ. ಏನು ನೋವಾಗಲ್ಲ, ಚುಚ್ಚೋದಿಲ್ಲ, ನೋವಾಗಲ್ಲ. Like it was demonstrated in the previous patient, we are marking on the arm our controls, positive and negative controls, saline and histamine. Start. Okay, start ಮಾಡಿ. ಹಾಕಿ. We are placing a drop of saline, histamine, and then we are also placing a drop of saline. In ಸ್ವಲ್ಪ ಹಾಕಿ. We now take a lancet and gently insert the allergen into the skin without pricking the patient too hard. Is itna hi bas. After every allergen you clean the lancet. बस उतना ही लगा आपको? नहीं ना? Now we wait for a few minutes to see the reaction. ಅದು ಲೇಬಲ್ ಮಾಡಿ, H ಮತ್ತೆ S. ಹಾ. Okay. ಅಷ್ಟರಲ್ಲಿ ಬೇರೆ ಮಾರ್ಕ್ ಮಾಡ್ಕೊಳ್ಳಿ. आप आराम से हाथ नीचे रखो, रिलैक्स करो. ಕಾಟನ್ ಡಸ್ಟ್ ಮಾಡಿ. इधर कुछ खुजली जैसा होता है तो बताइए. हो रहा है, चुभ रहा है यहाँ पे कुछ नहीं. दर्द हो रहा है या खुजली जैसा हो रहा है, कुछ लग रहा है? ओके. ಇಲ್ಲಿ ಏನೇನು ಹಾಕ್ತಿದ್ದೀರಾ?
ಕಾಟನ್ ಡಸ್ಟ್ ಆಮೇಲೆ ಡಸ್ಟ್ ಮೈಟ್ಸ್.
ಓಕೆ. We are placing the allergen samples of house dust mite, cotton dust, other variants of house dust mite and cotton dust. Meanwhile, we will wait and observe for our control. We can already see ಇಲ್ಲಿ ಇದು ಸ್ವಲ್ಪ ವೈಟ್ ಮಾಡಿ. ಇದು ಮಾಡ್ತೀನಿ ಬಿಡಿ ನಾನು. ಹಾಂ, ನೀವು ಇಟ್ಕೊಳ್ಳಿ, ನಾನು ಮಾಡ್ತೀನಿ. Now I am continuing with the test. Allergen number 1. ಇದೇನು?
ಅದು ಡಸ್ಟ್ ಮೈಟ್ಸ್.
House dust mite.
ಡ್ರೈ ಸ್ಕಿನ್ ಇರೋರಿಗೆ ಬೇಗ ಇದು ಕಾಟನ್ ಡಸ್ಟ್.
Cotton dust. बस को लगा? मेरे तरफ करो, उस तरफ करो, उस तरफ, उस तरफ, उस तरफ. हाँ, ऐसे रखो. हाँ, ऐसे. We can see a wheel and flare reaction in the histamine control, positive control. Measure ಮಾಡಿ. Almost 4 mm. And there's no reaction in the negative control, that is saline. I think that should not be one reaction. Avaga test is on.
No, then you put one more circle next to it and prick again without the blood coming out. And just every time wipe it up, don't forget to do that.
ಇದು ವೈಪ್ ಮಾಡಬೇಕು. ಇದ್ರ ಪಕ್ಕನೇ ಮತ್ತೆ ಹಾಕೋಣ. ಇದು ಮ್ಯಾಮ್ ಇದು ವೈಪ್ ಮಾಡಕ್ಕೆ ಹೇಳೋದು. ಅದಕ್ಕೆ दर्द हो रहा है? नहीं ना? यहाँ पे खुजली हो रहा है?
नहीं.
ಡಸ್ಟ್ ಮೈಟ್ಸ್ ಕಾಟನ್ ಡಸ್ಟ್ ತೋರಿಸ್ತೀವಿ. ಟೈಲರ್ ಇಲ್ಲ,
ಡಸ್ಟ್ ಅಲರ್ಜಿ.
ಅದು ಬಟ್ಟೆ ಕೊಡುವಾಗ
ऐसे रखो.
I will use
ಮಾಸ್ಕ್ ಹಾಕ್ತೀರಾ?
ಇದು ಟೈಮ್ ತಗೊಳ್ಳುತ್ತೆ ಅಲ್ವಾ? 10 minutes. ಕೂತ್ಕೊಳ್ಳಿ ನೀವು. ಮ್ಯಾಮ್, ನೆಕ್ಸ್ಟ್ ಪೇಷಂಟ್ ಏನಾದರೂ ಆದ್ರೆ ಹೇಳ್ಬೇಕು. ಹೌ ಇಸ್ ನಿಶಾ? ಚೆಕ್ ಆನ್ ಹರ್. ಹೂ ವಾಂಟ್ಸ್ ಟು ಗೆಟ್ ಇಟ್ ಡನ್ ನೆಕ್ಸ್ಟ್? ಕಮ್ ಫಾರ್ವರ್ಡ್. ಮ್ಯಾಮ್ ಮಾಡ್ತೀನಿ. ವಾಲಂಟಿಯರ್ ವಿತ್ ಲೆಸ್ ಹೇರ್ ಇನ್ ದ ಹ್ಯಾಂಡ್. ಮ್ಯಾಮ್ ಬನ್ನಿ. ಓಕೆ, ಕಮ್ ಫಾರ್ವರ್ಡ್ ಕ್ವಿಕ್ಲಿ. ಮ್ಯಾಮ್ ಬನ್ನಿ. ಡಾಕ್ಟರ್ ಸಿಟ್ ಡೌನ್ ಫಾಸ್ಟ್. ಸಿಟ್ ಡೌನ್. ಚೇಂಜ್ ಮಾಡಿ.
First we have to clean. ಸ್ಪಿರಿಟ್ ಅದು ಒಂದ್ಸತಿ ಯೂಸ್ ಸ್ಟಾರ್ಟ್
ಅದು ಓಲ್ಡ್ ಪೇಷಂಟ್ ಹೊಸ
ಇಲ್ಲ ಇಲ್ಲ ನಾನು ತಗೊಂಡೆ
ಇವ್ರಿಗೆ ಅಂತ ತಗೊಂಡಿದ್ದೇನೆ.
ಇವ್ರಿಗೆ ಇವತ್ತು ತಗೊಂಡಿದ್ದು ಅಲ್ಲಿ ಹಾಕಿದ್ದೀನಿ ಪೇಷಂಟ್ಗೆ. ಹಾಂ ವರ್ಕ್ ಮಾಡ್ತಾರೆ ಒಂದೊಂದು ಟಿಕ್ಕಿಗೂ ವರ್ಕ್ ಮಾಡ್ತಾರೆ. ಡ್ರೈ ಸ್ಕಿನ್ ಸ್ವಲ್ಪ ಹಾರ್ಡ್
So we have to wait for
house dust mites, sneezing in morning itself.
after going to bed.
ಇಟ್ಕೊಳ್ತೀರಾ ಕಾರ್ಟೂನ್ ತಗೊಂಡ್ಬಿಡುತ್ತೆ ಒಂದು ಟಿಕ್ಕಿಗೂ ಬೈ
Even white one. Let them do some white. ಅವಳಿಗೆ
ಇಲ್ಲ ನಾನು ಬರ್ತಾ ಇದೆ ಬ್ಲಡ್ ಬಂತ ಸ್ವಲ್ಪ ಸ್ಲೋ ಮೇಡಮ್ ಕರೆಕ್ಟ್ ಆಗಿದೆ
ಇವೆಲ್ಲ ಸರಿಯಾಗಿದೆ.
ಹಾಂ ಇದೆಲ್ಲ
ಫಸ್ಟ್
ಟೈಮ್ ಜಸ್ಟ್ ಎಪಿಡಲ್ ಸ್ಟಿಚ್ ಯಾವ ಥರ ಆದರೂ ಮಾಡ್ಕೊಂಡು ಅದು 1-5 minutes ನೋಡಿ ಇಷ್ಟನ್ನು ರಿಯಾಕ್ಷನ್ ಬರ್ತಿದೆ ಅಂತ ಗೊತ್ತಾದಾಗ ನೆಕ್ಸ್ಟ್ ಅದು ಇಷ್ಟಾದ್ರೂ ಬರ್ಬೋದು ನೆಕ್ಸ್ಟ್ ನಾವು ಮಾಡ್ಕೊಂಡು ಹೋಗ್ತೀವಿ ಅದಕ್ಕೆ ವೇಟಿಂಗ್ ಪೀರಿಯಡ್
ನಮ್ಮವ್ರು ಯಾರಿದ್ದಾರೆ ನೀವು ಏಪ್ರಿಲ್
ಯಾವ ಕೋಟಿ ಕಾಮನ್ ಪೋಲನ್ ಪಾರ್ಥೇನಿಯಂ ಗ್ರಾಸ್ ಅಂಡ್ ಆ ಥರ ಗ್ರಾಸ್ ಇದೆ
Okay, sir.
I request everyone to be seated. We have another talk to conclude the session. Meanwhile, I thank Soumya ma'am for simplifying the procedure and for practical demonstration.
Yes, sir.
We will now move on to our talk on FOT and spirometry. Meanwhile, the skin prick test volunteers will be assessed at the end of this talk. Assessing lung function is key in managing allergy and asthma. To help us understand FOT and spirometry, I invite Dr. Vasavi Sai, Senior Resident, Department of Pulmonary Medicine, to take the stage and present the session.
ಅದು ಒಂದೊಂದಕ್ಕೆ ವರ್ಕ್ ಮಾಡ್ಕೋಬೇಕು ಫಸ್ಟ್ ಪಿಕ್ ಮಾಡೋದು ಇದು ಡಸ್ಮೈಟ್ ಹಾಕಿರೋದಿಲ್ಲ 3 ಡಸ್ಮೈಟ್ಸ್ ಹೌಸ್ ಡಸ್ಮೈಟ್ಸ್ ಅದು ಮಿಕ್ಸ್ ಒಂದ್ಸತಿ ಪ್ರಿಕ್ ಮಾಡಿ ನೋಡ್ತೀನಿ ಅಷ್ಟೊಂದು ಮಾಡಬೇಡ ಸ್ವಲ್ಪ ಸ್ಮೂತ್ ಆಗಿರಲಿ ಜಸ್ಟ್ ಅದು ಎಪಿಡರ್ಮ್ ಟೆಸ್ಟ್ ಮಾಡಬೇಕು ಹಾಂ ಸ್ವಲ್ಪ ಸ್ಲೋ ಮಾಡಿ ಪಿಕ್ಕಿಂಗ್ ಕರೆಕ್ಟಾಗಿದೆ ಹಾಂ ಸಾಕು ಯಾಕಂದರೆ ಜಾಸ್ತಿ ಹಾರ್ಡಾಗಿ ಹೋದಾಗ ಬ್ಲಡ್ ಬರುತ್ತೆ ಹಾಂ ಅದು 3 ಡಸ್ಟ್ಬಿನ್ಸ್ ಬರುತ್ತೆ ಥ್ಯಾಂಕ್ ಯು ಸರ್ ಥ್ಯಾಂಕ್ ಯು ಸೊ ಮಚ್ ಥ್ಯಾಂಕ್ ಯು ವೆರಿ ಮಚ್ ಡಸ್ಟ್ಬಿನ್ಸ್ 3 ಡಸ್ಟ್ಬಿನ್ಸ್ ಥ್ಯಾಂಕ್ ಯು ಸರ್
measure by
I request all the volunteers to take your seat.
red light ಇದು ವರ್ಕ್ ಆಗುತ್ತಾ ಯಾವುದು ಯಾರನ್ನು ವರ್ಕ್ ಆಗುತ್ತೆ
Good afternoon to esteemed speakers, respected delegates, and dear students. Myself, Dr. Vasavi, Senior Resident from the Department of Pulmonary Medicine. I am here to give a short talk and demonstration regarding the FOT and as well as spirometry. Coming to lung functions, there are like ventilation and gas as well as gas exchange is the main lung functions. This ventilation this depends upon the airways and lung volumes and as well as lung mechanics as well. Our spirometry and as well as we are going to talk about forced oscillation technique able to detect the abnormalities within the airways. That is, if any airflow problem is there, we can able to detect with the help of spirometry and as well as so-called FOT, that is full form is forced oscillation technique. So coming to spirometry, which is just a physiological test, it is able to detect the volume of a particular patient over a period of time. If since so many ages, this is the most common pulmonary function test which everyone is practicing. It mainly measures the FVC, which is called forced vital capacity, and FEV1, which is represented as forced expiratory volume in the first second. In a normal individuals, FEV1 will be more than or equal to 80% of the predicted value, whereas FVC will be more than or equal to 80% of predicted to that particular individual. Whereas ratio FEV1 by FVC will be more than 0.7. The spirometry will measure the various volumes and capacities, but it can't measure residual volume, functional residual capacity, and total lung capacity. Let us discuss how we are going to perform a spirometry. It is mainly a 4-step process. First, we will ask the patient to take a deep maximum effort, deep inspiration. Then step 2, we'll ask the patient to have an force blast out of an expiration in the first second. Then step 3 is we'll encourage the patient to have continuous exhalation for minimum of 6 seconds. This minimum of 6 seconds is very important in the case of procedure of spirometry. And step 4 is like patient has to be asked to take the inspiration to maximum flow back. Here is a demonstration. Here is a demonstration showing how we will perform spirometry in our department. First, our respiratory therapist is explaining the patient how spirometry has to be performed. First, patient has to take deep inhalation with a blast of air in the first second of expiration. Then he has to expire for 6 seconds and then he has to take the deep inspiration. That's how we will perform spirometry in our department. Then this is a sample report of the spirometry where it will have 2 loops. One is flow volume loop, another is volume time graph, and these are the reference values for that particular individuals. Means it is individualized to particular person based upon his height, weight, BMI, and also as well as smoking status. Mainly, we will see this flow volume loop. With the help of this flow volume loop, we will able to detect the abnormalities in the airways as well as lung parenchyma. Let us discuss about some of the diseases which can be detected by spirometry. Coming to obstructive airflow obstructive disorders like COPD, asthma, bronchiectasis, cystic fibrosis, and post-tubercular obstruction, you can see a flow volume loop. The positive curve is the expiratory curve and negative curve is the inspiratory curve. In case of airflow obstructive diseases, we can see a scooped out expiratory curve as like a ice cream scooped out curve is seen in airflow obstructive disorders. Whereas in ILDs like restrictive diseases like fibrosing lung diseases, pneumoconiasis, interstitial lung diseases, pulmonary edema, you can able to see that flow volume curve is reduced in size, which means representing the volume of the lung will is reduced. Coming to the flow chart, which is representing which is able to detect the interpretation of the spirometry report. First, we have to check the FEV1 by FEC ratio, which it should be normally more than 0.7. If it is normal, then we have to check for FEC. If even FEC ratio is normal and FEC is also normal, then the patient is normal. It doesn't have any abnormalities in the airway or lung parenchyma. If FEV1 is normal, check FEC. If FEC is reduced, then person will be categorized under restrictive lung diseases. If the ratio is reduced, then it will represent obstructive lung diseases. We have to check for FEC. If FEC is also normal, it is combined obstructive as well as restrictive diseases. If ratio is reduced and FEC is normal, then it will represent pure obstructive diseases. In that pure obstructive diseases, we have to differentiate between asthma as well as COPD. For that, we have to do bronchodilator testing. If bronchodilator reversibility is there, it is probably asthma. If bronchodilator reversibility not there, it is probably COPD. But the procedure which we are doing for spirometry, so-called 6 seconds expiration, deep inhalation, everything has some problems. Like patient can't able to blow completely for 6 seconds. Patient can't complete the test. He will have that lack of blast effect during the first second of expiration, coughing during the blow, and he may take extra breath during the 6 seconds of expiration. And these spirometry cannot be performed in the children, elderly people, and as well as bedridden patients. This is a demonstration of spirometry problems we are facing during performing spirometry. Here, patient is stopping the procedure in between because he is unable to complete the test because of cough. Here, patient is unable to complete the test because he is unable to perform for 6 seconds. These are the most common problems which we will face while performing spirometry. Maybe next we are going to discuss about forced oscillation technique. This is just an upgradation in performing pulmonary function test, where we have seen the problems in spirometry like coughing, elderly people, children, bedridden patients, and forced expiratory effort. These all can be overcome with the help of this FOT machine, FOT technique. Coming to airway anatomy, as we all know, there are 23 generations of airway and dichotomous branching, and 1 to 15 is the conducting airways where there is no gas section will happen, and 16 to 23 is respiratory airways where gas section will happen. In FOT, there are two, we can able to detect the diseases in the FOT like large airway obstruction, small airway obstruction. In FOT, the large airways means it has taken up to the 8th generation, whereas small airway is that 8th and beyond the generation is taken as small airways. Resistance is more seen in the case of large airways. Resistance when compared to small airways, the large airways will be affected with the reduced lung volume, and airflow in the large airways are turbulent and convention, whereas in small airways it is laminar airflow. In FOT, the technique they are using, they are using a technique so-called sound waves, which was first introduced by Arthur Dubois, which is known as forced oscillation technique. In this, they have used a modified Ohm's law based upon resistance will depend upon the change in pressure upon flow. Here we have to know about a terminology known as impedance. Impedance is nothing but how much resistance is there in the airways, how much pressure is required to overcome that resistance in the airway. Means this some impedance is the pressure to overcome the resistance within the airways so that forward flow of air will happen. This is the in FOT, we are not asking patient to take deep inhalation or deep exhalation. We are just asking patient to have a patient quite normal tidal breathing. With the help of oscillator, we are producing sound waves, in pushing the sound waves into this lung. When we can measure a waveform, with this help of these waveforms, we are able to measure the resistance within the airways. It is finally like we are forcing oscillations of various frequencies into the lung, and whatever the pressure waves whatever the pressure waves are getting in the system are used to measure the resistance as well as reactance. In the FOT, we are mainly measuring up the impedance. Impedance have two components, which is resistance. Impedance has two components. One is resistance, another one is reactance. So resistance will be contributed by the airways, mainly large airways and small airways as well. Reactance will be mainly contributed by the volume of the gas and elastic properties of the small airways. It means reactance again have two components. One is inertance and elastance. So totally we should be knowing about the words known as resistance and reactance. Reactance again have two components. One is inertance and elastance. Coming to slight differences which we will observe in spirometry as well as FOT. In spirometry, it is mainly a sensor where patient has to take deep inspiration and then expiration for 6 seconds. Whereas in FOT, patient has only tidal breathing. Along with the tidal breathing, we are forcing oscillations of either single frequency or multiple frequency depending upon the machine, so that we can able to measure the resistance in the airways. Patient cooperation is very much needed in the case of spirometry, whereas in FOT only tidal breathing is required. Patient cooperation is not that much necessary. We can able to diagnose the bronchodilator response also in a patient with spirometry. Like if an FEV1 change is 12 more than or equal to 12%, when you can say it as bronchodilator response. Whereas in FOT also, we will see certain parameters like resistance, reactance, and curves. If there is any change, 30% in R5, 40% in X5, and 50% is decrease in AX, it is represented as bronchodilator response, good bronchodilator response. So as I already told, FOT is slightly different from spirometry because it doesn't require any effort from the subject and can be performed with tidal breathing, and it requires only minimal patient cooperation. It can be performed in a children, elder patient, on ventilator patient, and post-operatorily before giving fitness for a surgery patients and spirometry related bronchospasm related. It can able to diagnose the obstructive airway diseases like asthma, COPD, small airway obstructions like bronchiolitis and asthma. Then ILDs like hypersensitivity pneumonitis, fibrotic ILDs, and as well as can be used to diagnose the lung function in a case of post-lung transplant. These are few pictures which is showing FOT can be done in a child. FOT can be done in a patients who are bedridden and as well as in a patient admitted in the ICU as well. How we can perform the FOT. Patient should be seated comfortably. We can perform FOT even when the patient is sleeping, but most likely seated position is the most comfortable position. And patient nose should be clipped with a nose clip, and neck should be in neutral. Cheek should be supported, and mouthpiece should be firmly sealed with the lips. Patient has to take a deep tidal breathing of 30 seconds. Minimum 3 readings are required to interpret the report. This is a demonstration video how we are performing FOT in our department. Our respiratory therapist is instructing the patient how he has to perform the FOT. Patient has to take normal tidal breathing. Machine will give forced oscillations. It won't disturb the patient tidal breathing. Nose will be clipped with a nose clip, and he has to seal the lips around the mouthpiece. We will measure resistance, reactance in a FOT report. Remember one thing, the lower frequency will travel longer distances, the higher frequencies will travel the shorter distance. So this is just a sample report of FOT, where you have to see the resistance, reactance. The positive deflection represents the resistance, whereas the negative deflection represents the reactance. The x-axis will have frequencies, whereas y-axis will have the resistance. The R5, the resistance at the 5H is represented by R5. Resistance at 20H will be represented by R20, whereas reactance at 5H will be represented as X5, whereas reactance at 20H will be represented as X20. This triangle is known as area under curve, which is represented as AX. The xy is usually negative deflected. It will reach the positive deflection. The point where xy is reaching the positive, reaching the zero is represented as FRES, known as resonant frequency. We have to think about R5, R20, X5, AX, and FRES. Based upon these values, we will interpret the FOT report. As I already told, the distance traveled by the sound frequency is inversely proportional to the distance. Like it is inversely proportional to the frequency. Like if lower frequency, they will travel the entire lung, whereas higher frequency will travel up to only larger airways. X5 represents the reactance at 5H, which is represents the elastic property of the small airway as it is lower frequency, whereas X20 represents reactance at 20H, whereas AX represents the area of reactance. FRES is resonant frequency. These are the normal values. The reference values will change from machine to machine based upon the guidelines. This is the sample FOT report, which is showing like we have to enter the name, age, sex, height, weight, BMI, smoking status of this particular patient. It will give particular predictive values of that particular individual. Like the reference values will be individualized to a particular person. Then this is the reactance graph. Sorry, this is the resistance graph, and this is the reactance graph. Coming to interpretation, as I already told, R5 represents small air, like 5 represents that lower frequency will travel up to the small airways. So R5 will be increased in case of small airway obstruction, whereas in R20 will be normal as it travels only up to large airways. Whereas R5 minus R20 represents pure small airway obstructions. It is increased as it is small airway obstruction. So X5, AX, and FRES, everything will be abnormal. Whereas in pure large airway, as R20 represents only will reach up to large airways, so it is increased. As R5 is crossing large airways, it is also increased in case of large airways obstruction, whereas remaining parameters will be absolutely normal in large airway obstruction. Whereas in restrictive lung disease, as it is restrictive lung disease, so airways resistance will be normal. So R5, R20, R5 minus R20, everything will be normal. Whereas X5, AX, FRES everything will be abnormal. It is increased and more negative. There is some disorders where there is combined large as well as small airway obstruction is there, where everything will be abnormal. We can able to see the bronchodilator response in FOT as well. Next, coming to interpretation of the reports, as I already told, in large airway obstruction, R5 will be increased. This is the frequency. This is the R5 is increased. Then R20 is also increased, whereas R5 minus R20 will be absolute near to normal. As a 0.45, it will be near to normal. As it is pure large airway obstruction, the X5, FRES, and as well as AX, everything is within the normal limits. So this report interprets the pure large airway obstruction. Coming to next report, where R5 is 7.48, which is represented it is increased, whereas R20 is near normal. R5 minus R20 will obviously be increased. X5 is, this is the X5. X5 is near to minus 4.62. It is increased. FRES should be near, it should be up to 15, but it is almost 24.98. It is very increased, and AX is also increased. It is representing means R5, R20 is normal except R20. Everything is increased. It's representing pure small airway obstruction. Whereas coming to this report, R5 is in normal, R5 minus R20 means resistance, everything is normal. Only reactance graph is showing abnormality. So it is representing restrictive lung diseases. This is a gist of all the reports. It is normal spirometry where resistance and reactance is normal. This is the obstructive airway diseases spirometry where expiratory curve has scooped out appearance and showing this R5 is increased, R20 is normal, whereas reactance curve is also abnormal. There are some limitations in FOT as well because there is interference from upper airway artifact like movement of tongue and swallowing. It is little expensive, but now up to now there are no universal reference values. So this is just a summary of whole talk. But we pulmonologists believe that FOT cannot be completely replace spirometry, but it is very, very good adjunctive if we are using, if it is available. Thank you so much.
Thank you, everyone. With that talk, we conclude our CME. Lunch has been arranged. Please enjoy your meal. And thank you all for joining us today.